Good evening, guys. Sorry, stuck. I was stuck. Everything was stuck. It is time. Yes, I know it is time. I usually am not late. Usually be on time. No class not started. Dr. Meghna, Dr. Himanshu. Good evening. MacBook Air. Kunoichi. Kunoichi. Putting my phone on the airplane mode. Good evening. Good evening. Good evening. Good evening. Good evening. So let us start today. And again, the class is going to be from 7:30 to 9:30. It's time to go. Yes. Again, time from 7:30 to 9:30. Then dinner. Time 9:30 to 10. Then final 10 to 12:30 or 1. Okay. Today we have a little longer session. Okay. Correct. Okay. Chalo. Let us start. So we are going to start with neuro-ophtha. Okay. Neuro-ophtha, nerves related to ophtha, nerves in ophthalmology. Which are the nerves which are there in nerves ophthalmology? Yes. Second, third, fourth, and sixth. Okay. Third, fourth, sixth for movements. Okay. And second is for your vision. Second is for vision and other features. This is for movements. Okay. So let us start. So in this, we'll want to learn optic nerve assessment, papilledema. Papil. What is papil? Papilla. What is papilla? Papilla is the optic nerve head. Optic nerve head is called as papilla. Okay. Correct. That is it. So papillitis is inflammation of the optic nerve head. Okay. Then we talk about pupil reaction abnormalities, Marcus Gunn, ADs, Argyll Robertson, Horner syndrome, Hutchinson. These are all MCQs. These are all MCQs. Visual pathway. This is a very, very important MCQ. I am going to draw a 5-star here. Okay. This is a 5-star topic. You should be knowing about this definitely. Okay. Then we'll talk about these Sklenar pathways. This is how we'll proceed about with optic nerve. Okay. These are the parts of optic nerve. Parts of optic nerve. Please remember this anatomy. There are 4 parts: 1, 2, 3, and 4. There are 4 parts. Okay. Intraocular part, which is the smallest one, and intraorbital part, which is the longest one. Okay. Which is the longest one is the intraorbital part, which is responsible for the sideways movements of the eyeball. Only then it can move. Okay. Intracanalicular part is the one which is most susceptible to head trauma. Okay. Intracanalicular is the one which is most susceptible to head trauma and crush injuries. Okay. Intracranial is the part which is in the brain. And where does the optic nerve end? It ends at the optic chiasma. And beyond the optic chiasma is the optic tract. This is the optic tract. Okay, optic chiasma is beyond is optic tract. Okay. Now, where do the optic nerve fibers relay? Where do they relay? They relay at which part? They relay at the LGB. Yes, lateral geniculate body. Lateral geniculate body is the part where the optic nerve fibers will synapse and the relay. Beyond the lateral geniculate body is the optic radiation. Okay. Beyond the lateral geniculate body is the optic radiation. Please remember optic radiations. Okay. Optic nerve is made up of which neuron? It is made up of second order neuron. Okay. This is made up of second order neurons. Okay. Optic nerve is made up of second order neuron, and second order neuron will relay at the lateral geniculate body. From the lateral geniculate body is the third order neuron. Okay. So optic radiation is composed of the third order neurons. Okay, these are all MCQs. Okay, third order neurons, which is there. Correct. Okay. Now, to assess the optic nerve, what are the tests that are done? Okay, what are the tests that are done to assess the optic nerve? This is vision, color vision, okay, visual field, that is perimetry. This we have done. This is perimetry. Then the reflexes. These are various reflexes. We'll be talking about them. And fundus is the examination of the retina and optic nerve head. Fundus is the examination of the retina and the optic nerve head. Okay. So please remember five things: vision, color vision, perimetry, that is how the optic nerve is conducting. Okay, that is perimetry. Then various reflexes. Okay, various reflexes are there. Then you have a fundus examination. These are the five tests. Okay, why do you need to know these five tests? When you talk about papilledema or papillitis or optic neuritis, we should be knowing how to talk about vision, color vision, perimetry, fundus, and your reflexes. Okay, correct. So for vision, these are the two charts. These are two types of charts. They can be asked. This is the Snellen's chart. These are the Snellen's chart. And this is the log mar chart. What is mar? Mar is minimum angle of resolution. Minimum angle of resolution. It is the logarithmic value of this, which is there. There are 5 letters in each line. Okay. Each line has 5 letters. Correct. Please remember this. Correct. Okay. Now, this is how the minute of angle is subtended. The minimum angle of resolution subtends a 5 minute of arc. What is the value of MAR? What is the minimum angle of resolution? It is 1 minute of arc. Okay, please remember it is 1 minute of arc. It is 1 minute of arc. Yes. The entire letter subtends 5 minutes at the respective distance. At the respective distance, it will subtend 5 minutes of arc. Please remember this. Okay. Now, one thing that you should be knowing is visual acuity of less than 6/18 is called as low vision. Is called as low vision. Okay. How much is in logmar? And how much is logmar? In it is 0.5 or less. It is 0.5 or less. Visual acuity is 0.5 or less. And please remember, higher the number, poorer the vision. Okay, please remember that it is inverse. So 0 is best. So 0 is best. Okay. Higher the number, poorer the vision. Beta 9.5 is not blindness, beta. It is low vision. Dr. Anukriti, it is not blindness, it is low vision, beta. Okay. Less than 0.5 is poor vision, low vision. Okay. Not blindness. Blindness is 3/60. Blindness is not there in logmar. Okay. Correct? Yes. As we go upward, so higher the log value, poorer the vision. Okay, poorer the vision. Please remember this. Correct? Okay. Now, so that was vision. Now coming to color vision. Second is color vision. Color vision is checked by these two tests. This is your Ishihara charts. Ishihara charts. And this is Farnsworth 100 U test. Farnsworth, Munsell 100 U test. Does this have 100 balls? How many balls are there? How many balls are there? 84. Yes, there are 84 balls. Okay, there are 84 rings which are to be arranged by the person. And yes, the color vision abnormality is tub per dog. Tub per dog. Green defect, red defect, and blue defect. Blue is tritanopia, tritanopia. Red is protanopia, and D is deuteranopia, deuteranopia. Okay, correct. Okay, good, very good. Next, we come to pupil reflex. My volume. Okay, I'll increase my volume. I'll try to increase my volume. Okay. Pupil reflex pathway. I think it would be better if you can increase the volume of your speaker. Okay. I am very sure it will be there. और विकास जी मेरी आवाज सुन रहे हो तो प्लीज इमोजीज ऑन कर दो. हम भी थोड़ा इमोजीज सुन लें. टर्न ऑन रिएक्शंस. यस, रिएक्शंस. हाँ, वोकल नोड्यूल हो जाएगा तो हम डॉक्टर प्रणीत से बात कर लेंगे. वी विल टॉक टू डॉक्टर प्रणीत. ठीक है. चलो. प्यूपिल रिफ्लेक्स पाथवे is more than is more than 0.5. Yes, more than. If the value is more than 0.5, then it is poor vision in logMAR chart. Yes, Dr. Michelle, absolutely good. लो हो गया. बोला कुछ ना कुछ चीजें समथिंग साइकोलॉजिकल ऑल्सो. यू शुड नॉट टेल कि वोकल नॉड्यूल हो जाएगा. आई एम ऑलरेडी फीलिंग एज आई एम गेटिंग अ वोकल नॉड्यूल. जस्ट बिकॉज यू मेंशन नाउ आई एम गेटिंग साइकोलॉजिकली साइक्ड. दिस इज हाउ साइकोलॉजी प्लेज अ रोल. ठीक है. सो यू हैव टू कीप टेलिंग योरसेल्फ. ओके. आ जाओ. Pupil reflex pathway. So this is how the pupil reflex pathway is. When light is given into the eye, the light travels to the same side, and light crosses over from the chiasma to the opposite side also. But very, very important point. Please remember this. This is very important point, that these fibers, they do not go to the lateral geniculate body. Okay, they will leave the optic tract before reaching the lateral geniculate body. Lateral geniculate body is somewhere here. Okay, lateral geniculate body is somewhere here. Okay, so the pupillary fibers, they will leave the optic tract before reaching the lateral LGB, and they will go to the pretectal nucleus. Okay, they will go to the pretectal nucleus, and each side pretectal nucleus stimulates both side Edinger-Westphal nucleus. So there are two crossings which are happening. One is a crossing which is happening here. Okay. One is a crossing which is happening at the chiasma. Second crossing is happening here from pretectal to the Edinger-Westphal nucleus. That is the reason when you give light in one eye, the same side pupil, the same side pupil reacts, that is the direct response. The other side pupil also constricts, that is called as consensual response. Consensual response. It is consensus. Okay. It is the consensus of the other eye also. When you move this torch from here to here, the same phenomenon will happen. The light will go to both sides. Now, but the name now reverses. This becomes direct, and this becomes consensual. Okay, correct, understood. But the pupil remains the same. The pupil remains the same. This is the pupil reflex pathway or light reflex pathway, and there are two places where the crossing over is happening. Okay, correct. Next, the next is the optic nerve triad, near triad. Okay, near triad, which is a three parts, which is three parts. One is convergence, second is accommodation, third is pupil reflex, which is meiosis. Pupil reflex, which is meiosis. Okay, this is the near triad. Okay, correct. Next, there is a ciliospinal reflex, ciliospinal reflex, ciliospinal reflex. Okay. In case of the noxious stimulus, there is dilation. Okay. There is dilation. Okay. I always say if there is a love bite and the girlfriend gives a love bite, your eyes will become a ting. Okay. So this is when there is this, there is dilation. Okay. Corneal reflex. Okay. There is eyes blink in response to tactile stimulation. What is the afferent and what is the efferent? Afferent is the fifth nerve. Afferent is the fifth nerve, and blinking is the seventh nerve. Okay, fifth and seventh nerve. Okay. Next is vestibulo-ocular reflex, also called as doll's eye reflex. Doll's eye reflex. Basically, it is checking the brain stem function. It checks the brain stem function. When you jerk the head to one side, okay, there is opposite movement of the head. Okay, there is opposite movement of the eyes. If I am giving the jerk to the right, the eyes will move to the left. If I jerk the head to the left, the eyes will move to the right. So this is the vestibulo-ocular reflex. The afferent is the eighth nerve. Afferent is the eighth nerve, and efferent is the third and sixth nerve. Okay, eighth nerve is the afferent vestibular. So this is, please remember, vestibulo-ocular. Okay, so vestibular is eighth, and horizontal movements lateral rectus medial rectus is by the third and the sixth nerve. So this is there. Okay, but a reflex है, it's a reflex. ठीक है, there is no torsional reflex. Torsional नहीं है. ठीक है, torsional. And fourth nerve also you cannot check, because when the eye turns, eye is a circle. When the eye turns, it is difficult to assess. Okay, correct. Yes. Okay. Next, the Bell's reflex. Bell's reflex is this. See at my face. When I am trying to close my eye, the eyeball is going up. When I close the eyeball goes up. This is what is called as Bell's reflex. Okay. The mostly up and out. It can go up and in also. Mostly is up and out, but it can go in also. Now, one MCQ that comes is a poor Bell's reflex, या poor Bell's phenomena is a contraindication to ptosis surgery, especially especially sling surgery, especially sling surgery. Okay, poor Bell's phenomena is a contraindication to ptosis surgery, especially which type of ptosis surgery? The sling surgery. Up and out. Uh, Sir, yes, when we go to sleep, our eyes go up. Out means ऊपर, in mean नीचे. Nah, up and out, beta. Up and out, up and in. So see, if I'm doing this, the eyeball, I don't know where my eye goes. I've never asked anybody. It is going up and in, or is it going up and out? Okay, up and in. Okay, mine is going up and in. Mostly it is up and out. So I am a special one. Okay. I am a special one. Okay, good. This is what it is. Now, oculocardiac, oculorespiratory, oculoemetic. Whenever there is pressure on the eyeball, there is decrease in the heart rate, decrease in the breathing, increase in nausea, vomiting. Okay, these are the various reflexes which. Okay, correct. Very good. चलो पैपलिडीमा. ठीक है, मतलब ये एबनॉर्मल है. एबनॉर्मल नहीं है, नॉर्मल है भाई. आई एम नॉट एबनॉर्मल, आई एम नॉर्मल. Okay, I am specially normal. So let us talk about papilledema. It is papilla edema. It is because of high race theory. There is exoplasmic stasis. There is exoplasmic stasis. Okay, because of the pressure in the CSF. Because of the pressure in the CSF, there is swelling of the axons, which is there. Okay, what can cause swelling, pressure on the CSF? That is thigh massage. Thigh is tumor, hemorrhage, and aneurysms, aneurysms, and infection, and various infection. You take these four things and you use it everywhere in the cranium, in the orbit, in the system. Okay, you do it. This is how you combine. So THAI, so any thigh massage will cause pressure. Okay, will cause pressure on the optic nerve, leading to papilledema, leading to papilledema. It is not a disease of the optic nerve. It is not a disease of the optic nerve. It is some other disease which is manifesting on the optic nerve. Okay, the pressure is being seen on the optic nerve. It is not a problem of the optic nerve. So, so if you talk about the clinical features, if you talk about the clinical features, the vision is normal. Okay. Color vision is normal. Pupil reaction is normal. Okay. Visual field is normal. Okay. Correct. Understood. On fundus examination, on fundoscopy, see the next page. Fundoscopy, see the next page. This is how it is seen. Okay. There is hyperinia. There is, you cannot see the disc margins. Okay. The disc margins are blurred. Disc margins are blurred. Okay. MCQ. Which is the first disc margin to be blurred? Which is the first disc margin to be blurred? Nasal. Okay. Correct. Little bit now. Okay. It is cracking. Okay. Cracking हो रहा है. There is a lag. अभी भी lag है. Is there a still lag? चलो, I believe ठीक है, अभी तो let us go, good to go. चलो, ठीक है. If it lags again, I'll maybe leave and join again. I'll have to do that. Okay, चलो, good. So apart from this, what is seen? There is a patterns lines. There is patterns lines. What are patterns lines? Patterns lines are folds in the retina. Folds in the retina. Okay, there is fold in the retina. ठीक है, correct है. लीव करके आई हैव टू ज्वाइन अगेन बेटा दिन. ठीक है, अभी करते हैं. डॉक्टर मंथन, मे बी यू कैन लैग. लैगिंग अभी फिर से. ओके, देन व्हाट आई विल डू इज जस्ट गिव मी 2 minutes. आई लीव, आई ज्वाइन अगेन. ठीक है, आई लीव, आई ज्वाइन अगेन. जस्ट गिव मी 2 minutes. Again, let me put my phone to airplane mode so that it does not disturb. So, and okay, so vision is normal, color vision is normal. We were talking about this. So, pupil reaction is normal. What is the, you can see a amaurosis fugax. Okay, amaurosis fugax. What is amaurosis fugax? It is transient episode of blurring of vision. Transient episode of blurring of vision. Okay, correct. Everything okay? Everything's okay. चलो, ठीक है, अब तो कोई दिक्कत नहीं है. गुड. चलो, थैंक यू. एंड इमोजीज भी और बैंक नहीं, नहीं लूटना नहीं है कुछ भी. चलो, ठीक है. एंड हाँ, so field is normal. Field is normal. What is the other thing? There is enlargement of physiological blind spot, physiological blind spot. ठीक है, please remember these MCQs. This is an MCQ, MCQ, ठीक है, and patterns lines. This is MCQ, nasal margin. This is the MCQ. Okay, these are the various MCQs which are there. Patterns lines are folds in the retina, beta. You see concentric folds in the retina in papilledema because of the edema. See, whenever you get, whenever you keep your hand dipped in water for a long time, what happens here? You see those folds now? That kind of folds are seen in the retina. Okay, that is because of the edema. Constant edema, you see, okay, correct, that is there. Le beta, Karanveer Singh, hello. Chak to fatte. Yes, yes. Okay, correct. So, what is the treatment? Treatment is going to be treatment of the cause. Treatment is going to be treatment of the cause. There is no definite treatment of apathy. Okay, correct. Next is the benign intracranial hypertension. Benign intracranial hypertension, also called as pseudo tumor cerebri. Pseudo tumor cerebri. It is a diagnosis of exclusion. It is a diagnosis of exclusion. Important points are that CT scan is normal. All investigations are normal. You are not able to find no cause of papilledema is seen. Only finding CSF composition is normal. CSF composition is normal. Only finding is that the CSF opening pressure is raised. CSF opening pressure is raised. Okay, correct. What is this opening pressure? Opening pressure is when you do a lumbar puncture, you see that there is a gush of the CSF which is coming. Now, every time students get confused, that LP lumbar puncture is contraindicated in papilledema. Yes, it is contraindicated in papilledema. But if you have ruled out all the causes, okay, you do not know any cause, then under guarded prognosis, you can do a gentle lumbar puncture. It can be done. It is a diagnostic tool. Then it becomes a diagnostic tool. But if there is a tumor and you do a lumbar puncture, okay, then the brain will herniate down and the patient will die. So in case of a known cause of papilledema, you will not do a lumbar puncture. But in case you are not finding any cause, then for diagnosing, you have to do the LP lumbar puncture. So this is where you come out to know CSF opening pressure. Understood what is CSF opening pressure? Okay. What are drugs which cause intracranial hypertension? These are fertility drugs, fertility, OCPs, vitamin A, lithium, steroids, epilepsy में phenytoin, tetracycline, drugs which give you false tension. There is no need to tension, but drugs which lead to false tension, these are the drugs. Okay. What is the treatment? What is the treatment? Treatment is lose weight because it is seen in fat, fertile female of 40. Fat, fertile female of 40. So fat, fertile, she is taking OCPs. Okay? She is taking OCPs. Okay. Lose weight, reduce salt intake, give diuretics, furosemide, furosemide, give carbonic anhydrase inhibitors, acetazolamide, so that the CSF production is reduced. Okay. And then you do a LP shunt, lumboperitoneal shunt, or a VP shunt, that is between the ventricles and the peritoneal cavity. You release the excessive CSF. This is the LP shunt or the VP shunt, which is done. Okay, these are the various treatment options for benign intracranial hypertension. You can also do Optic nerve sheath penetration. Optic nerve sheath fenestration. Fenestration is making holes. Optic nerve sheath fenestration can also be done. Okay, these are the various treatment options for the benign intracranial hypertension. Okay, beta. I'll be sharing this PPT. This PPT will be shared. So this page you will be getting as it is. Okay, correct. So now let us work hard. Okay. Now we come to optic neuritis. I always tell optic neuritis, if you understand the optic nerve anatomy, you will always remember that optic nerve can get inflamed here. It can get inflamed here. It can get inflamed like this. Okay. So this all is called as optic neuritis. Okay. This one is retrobulbar neuritis because it is behind the bulb. Okay. This is papillitis because it is the papilla, optic nerve head. Papilla is inflamed, so papillitis. And this one is neuro because it is nerve, retina because it is going into the retina. So neuro retinitis. These are the three things. This is how you classify optic neuritis. All three are optic neuritis. Okay, correct. Now, MCQ. In case of a retrobulbar neuritis, in case there is inflammation here, only here, they will not happen, all three will not happen together. Please remember, these are the three types. They will not coexist. They occur one by one. Okay? They can occur not one by one, sorry. They can occur separately in separate scenarios. Okay. So, in case this is inflamed, when the examiner is looking inside, examiner sees everything normal. Examiner is not able to see this. Okay. But the patient is not able to see because the conduction is not happening. The signal is not going. So this is what you say that neither the examiner sees anything nor the patient sees anything in case of a retrobulbar neuritis. Okay. Neither the patient nor the doctor sees. Okay. So this is what is the classical finding. See, neither the patient sees nor the doctor sees. It is a normal optic nerve is affected behind the eyeball. Here, the optic nerve head is affected. This is papillitis, retrobulbaritis, neuroretinitis. This is the macular star formation. This is how it is there. Okay, correct. This is the macular star formation. Okay, correct. This is the most frequent type in adults. This is the most common type in children. This is the least common type. It is seen with viral and okay. Here it is multiple sclerosis. So multiple sclerosis leads to what? Retrobulbar neuritis. Okay, correct. Now let us move ahead talking about the retrobulbar neuritis. The ONTT trial. ONTT, which was optic neuritis treatment trial. Optic neuritis treatment trial. This said that you give 1 gram intravenous methyl prednisolone per day for 3 days. Okay. This is irrespective of body weight. Please remember, this is irrespective of body weight. Okay. And this is followed by 1 milligram per kg per day oral steroid for 11 days. Total is 14 days. Okay, total is 14 days. Okay. Now, the important finding was that direct oral steroids are contraindicated. Direct oral steroid is contraindicated because it can lead to worsening of symptoms. Okay. Now, before starting the treatment, you would do a MRI. Okay, you would do a MRI. Okay. So Vision. Huh. Now let us talk about the clinical features. If we talk about the clinical features, what is going to be? Vision is abnormal. है ना? Neither the patient sees anything, nor the, I'm coming to that. Neither the patient sees anything, nor the doctor sees anything. So patient is not seeing, so vision is abnormal. Okay. What is happening to color vision? Color vision is also abnormal, especially for which color? Red color. Especially for red color. So vision is normal, abnormal, color vision is normal. What will happen to pupil reaction? What will happen to pupil reaction? Because the optic nerve is affected, so light will not go. Light will not go. This will lead to a RAPD. RAPD. Okay. What happens to perimetry? Visual field. What happens to perimetry? Yes, RAPD is also called as Marcus gun pupil. Marcus gun pupil. Okay, we'll do this. Okay. Yes, in perimetry, you see a central scotoma or you see a centrocecal scotoma. What is the difference between central and centrocecal? Central is in the center. Centrocecal. Centrocecal. Cecal is the blind spot. Okay. When there is a scotoma which is joining the center and the optic nerve head, the blind spot, then it is called as a centrocecal scotoma. But it applies to all. It applies to all. This applies to all. Vision will be affected in all, color vision will be affected in all, pupil reaction will be affected in all, perimetry will be affected in all. Yes? Okay, Dr. Michelle? Yes, it is mostly unilateral, but maybe bilateral. It is mostly unilateral. Okay. Now, ocular movements. Ocular movements are painful. When there is inflammation, then there is pain. Ocular movements is painful. Okay. Cecal is the blind spot, beta. Dr. Picanid. Cecal is the blind spot. So a scotoma which is joining the center and the blind spot together, that is centrocecal. Okay, correct. So newer modalities are these glatiramer acetate. Investigation. What are the investigations? What are the investigations? So I was telling you, you do MRI brain to see for any demyelinating lesions. Demyelinating lesions. Okay. You can do a VER. What is VER? VER is visual evoked response. Visual evoked response. It is basically an EEG from the occipital cortex. From the occipital cortex. In response, it is basically an EEG from occipital cortex in response to light stimulus. To light stimulus. Okay, correct. Yes, before treatment, or you can start the treatment. You should not wait. You start the treatment and you send the patient for these investigation. You have to give IV methyl prednisolone for 3 days. Na? Give it for the first day and send the patient. Okay. By that time, the patient will come with the reports. Okay, VER. So VER is EEG from the occipital cortex. So there are two things that you need to see in this. One is amplitude and second is latency. Okay. One is amplitude and second is latency. Amplitude is decreased and latency is increased. Okay. Amplitude is decreased and latency is increased. This is the response in VR. These are the investigations. Okay. Correct. And treatment, I've already told you. The newer treatment are this glatiramer acetate, fingolimod, and natalizumab is the most recent treatment option. આજકાલ everywhere it is Zumab. So here is natalizumab. Okay, correct. These are the newer modalities. So this is how you can differentiate between papilledema and optic neuritis. See here, you were asking na laterality. So this is usually bilateral. This is usually unilateral. Okay. Vision is normal till late set. It is reduced. Okay. Pain is absent. Pain is present. Okay. Pupil reaction. is normal. Pupil reaction is RAPD. Okay. Visual field. Here is enlargement of the blind spot. There is a central or a centrocecal scotoma. Color vision is not affected. It is affected red color. CT MRI for space occupying lesion for demyelinated disorders. Okay, correct. Recovery of vision may not complete. Usually complete after adequate treatment is usually complete. Okay, I hope this is a very good chart to learn about papilledema and optic neuritis, but you should be knowing about this. Okay, please under papal edema, optic neuritis. Okay, correct. Everything is written here. Next, there is no disease which is called as optical dactylitis. Okay, there is no such disease. It is not a shitty outlook to life. You should not have any shitty outlook to life. You should always be happy. Okay, just be chilled. Okay, this we have already done. This is the pathway, pupil reflex pathway. है ना? Pupil reflex pathway we have already done. So I'll not waste time here. Let us move to various types of anisoporias. Okay, various types of pupil abnormalities. Okay, Marcus gun pupil also called as RAPD. It is settled by a swinging flashlight test. Okay, caused by lesion of the optic nerve, multiple sclerosis, trauma, and any disease related to optic atrophy. Correct. Understood. This is Marcus gun pupil. Home Eddy's pupil. Holmes Eddy's pupil. It is unilateral. Reason is unknown. Lesion in the short ciliary nerve or the ciliary ganglion. It is benign in nature. Pupil constricts with a diluted pilocarpine. Pupil constricts with a diluted pilocarpine. Okay. Horner syndrome. It is a lesion of the sympathetic pathway. Lesion of the sympathetic pathway. The triad is ptosis, meiosis, and hydrosis. This is the triad. Okay. Ptosis, meiosis, and hydrosis. It can occur with Pankos tumor, trauma, or stroke. Okay. This has come as an MCQ. This has come as an MCQ. Recently, it was there as an MCQ. Okay. Yes, heterochromia in the congenital one, but it has not never come as an MCQ. Dr. Astral, Codex syrup. It has never come as an MCQ. Okay, so let us not waste our time. Accommodation reflex. Argel Robertson pupil. Seen in neurosyphilis. Seen in neurosyphilis. Okay. It is caused by lesion in the pretectal area. So there is accommodation reflex present, pupil reflex absent. So P R A R P Argel Robertson pupil, pupil Robertson Argel. Okay, PRAARP. Very easy to remember. Usually bilateral, obviously, because it is in the brain stem. It is located in the brain. The lesion is the brain stem. These are the various types of pupil abnormalities which are there. In detail, we have discussed this swinging flashlight test, optic neuritis, Marcus gun pupil lesion of optic nerve. We have done this in our class. ADIS pupil today we are revising. It is the lesion of the ciliary nerve or the ciliary ganglion. This is where the ciliary nerve or the ciliary ganglion is there. This is in the orbit. So this is in the orbit. So obviously it is going to be unilateral because it is going to be in orbit. So it is going to be unilateral. Okay, arrow, beta. Pupil constricts with diluted pilocarpine. This is because of the receptor level upgradation. Receptor level upgradation. Okay, correct. That is there. Okay, and ADIS syndrome is seen in young females when there is absent knee jerk. Absent knee jerk. The reason is unknown. Okay, the reason is unknown. We do not know. It is unknown in nature and it is benign. There is no problem, but it is very commonly seen. ADIS people. Okay. Argel Robertson people, we are done. Accommodation reflex present is lesion. Where is the pediatric area? So this is where it is. This is the lesion where it is. It is here. It is here. between the pituitary nucleus and the Dengar-Westphal nucleus. Okay, between the pituitary nucleus and the Dengar-Westphal nucleus, this is where the problem lies. What are these neurons called as? These neurons are called as internuncial neurons. These are the internuncial neurons. It is a lesion of the internuncial neurons. Okay, correct. ठीक है नहीं, it is absolutely both sides बेटा. It is bilateral. See here, it is bilateral because it is in the brain stem ना, it is in the brain, so it will lesion will be there. It is both sides बेटा. ठीक है. Horner syndrome, ptosis, meiosis, and hydrosis, anophthalmos, and somebody was saying there is your hypochromia, heterochromia or hypochromia in case of a congenital problems. Okay, congenital type Horner syndrome, there is hypochromia. Okay, correct. See, ptosis, meiosis, this is how the MCQ comes. And then you are able to see this. Why is ptosis there? MCQ. Why is ptosis there? What is the reason for ptosis? Yes, which is the Muller's muscle. It is the Muller's muscle. MCQ. How much is the Muller muscle causing lid elevation? How much is the elevation by the Muller muscle? It is 2 millimeter. MCQ. What is the innervation of Muller muscle? It is sympathetic. It is sympathetic supply. Okay. These are the various MCQs that can come on Horner syndrome. Correct. Okay. Yes. What is the treatment? What is the surgery? Surgery is your Fasanella Servat operation. Fasanella Servat operation. What is Fasanella Servat operation? It is tarso. It is tarso-Muller-ectomy. Okay. If you understand the term, it is tarsal plate, Muller's muscle, ectomy is cutting. Okay. But a levator function will obviously be good na. In Horner syndrome, it is going to affect the Muller's muscle only. So obviously levator function will be good because LPS has a third supply. LP has a supply of third nerve. Okay. LPS has a supply of third nerve. Frontalis sling when done. बेटा वो करेंगे हम. We'll come to frontalis sling in late. ठीक है. बाद में आते हैं. Now, Hutchinson pupil is seen in head trauma. Hutchinson pupil is seen in head trauma. Okay. When there is head trauma, the same side pupil constrict. Pupil on the side of injury constrict. The other side pupil is normal. Okay. Then second, so this is level 1, stage 2, stage 3. Stage 1, stage 2, stage 3. In stage 2, the same side pupil dilate. Injured side become dilated. Okay. And pupil on the other side constricts. Okay. And finally, in stage 3, both side pupil are dilated. This is called as blowout pupil. This is both the pupils are blown out. It is basically urgent need for decompression. Urgent need for decompression. Okay. This is the blown out pupil. Correct. Understood. This is the Hutchinson pupil. Next is hemianopic pupil. Hemianopic pupil. Hemi is half. Half. Anopic is field. Hemi is half. Anopic is field. Okay. It is seen in the optic tract lesions. Obviously, it is seen in the optic tract lesion. In the same eye, when we put light from one side, the pupil will not react. Pupil will not react. When you throw the light from the other side, the signal goes and the pupil reacts. Okay. In the same eye, when you throw light from one side, the pupil does not react. In the same side, when you throw the pupil from the other side, the pupil reacts. Okay. See here, the signal is going good. The result signal is going. Whereas, sorry, ulta. एक second. So ये ऐसे. This is the same side. This is how this is going. And red, like region this. Okay, the signal is not going. So red, it is not going. and green it is going. Okay, correct. Voice crack again. Voice crack again. Now good. चलो आ जाओ. ठीक है. Visual field effects. These are visual field effects which are very very common. So somebody was asking center scotoma. See here. This is how the central scotoma looks like. ठीक है. Central scotoma looks like. Okay. बेटा वर्निक्स हेमियोनोपिक pupil में if it is light is shone from one side, the pupil does not react. In the same eye, if you throw the light from the other side, the pupil reacts. As you can see here in this diagram, when you put the light on the green part, the pupil constricts. When you put the light on the red part, the pupil does not constrict because it is not going. Okay, correct. ठीक है चलो. Now, visual field effects. Visual field effects. Yes, crossing of, nahin, not radiation. Crossing of the optic nerve fibers, beta, not radiation. Okay. Now, B is monocular visual loss, bitemporal myopia. Okay. This is heteronymous. This is heteronymous. What is hetero? What is nymous? Hetero is opposite. Nymous is side. Okay. All lesions beyond that are homonymous. Homonymous. Only on the optic chiasma, only at the optic chiasma, you will get a heteronymous field effect. You can write this down. Those who do not remember, only at optic chiasma, you will get a heteronymous field effect. Okay. If you see any question where one eye has right defect, other eye has left defect, just mark optic chiasma. Okay. If you see any lesion which is on the same side, see this side also left, this eye also left, both eye has left. Okay. Then it is beyond the optic chiasma. Then it is beyond the optic chiasma. Please remember this. Okay. This is very, very important point that only at the optic chiasma you will get the heteronymous field effect. One, is this clear? Is this okay? Second, pi in the sky, pi in the sky is seen in temporal locations. Okay. Pi in sky is seen in temporal lobe lesions. I always easily remember ST. Sky is S and T is, okay. This is temporal lobe lesions. Okay. Pi on floor. F. F becomes P. F becomes P. This is parietal lobe lesions. Okay. Floor becomes P. Okay. Floor becomes P. Parietal lobe lesions. Okay. Pi on floor. This is pi on floor. This is pi in the sky. Okay. Correct. Next is very important, which is at the occipital cortex. This is at the occipital cortex. If you can see here, can you see that there is ulta P? Ulta P, mirror image of P. Mirror image of P. So this is posterior cerebral artery embolism. Posterior cerebral artery embolism. Posterior cerebral artery embolism. If you see a lesion which is this, if you see a lesion which is like this, okay, this is middle cerebral artery embolism. This is middle cerebral artery embolism. Okay, please remember. Okay, if it is lesion is in the center, then middle cerebral artery. If lesion is in the sparing the center, then P, posterior cerebral artery embolism. Both are lesions of the occipital cortex. Okay, do not get confused between this and this. Do not get confused between this and this. In one, please see it is a bilateral phenomena. Here it is a unilateral phenomena. Okay, one. Second, please understand. Second thing, that this is going to be a D-shaped lesion. Okay, this is going to be, it will not be a circle. It will not be a circle. It will be a D-shaped lesion. Here, it is going to be a circular lesion. Here, it is going to be a circular lesion. Okay, correct. Understood. And please understand. Second, always, 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 the lesions are on the opposite side. Lesions are on the opposite side. So if the field effect is on the left, the optic tract is gone on the right. If the field effect is to the left, optic tract is on the right. If the field effect is on the left, optic radiation is on the right. Okay, opposite to field effect. Yes, please remember this. These are very, very important. बेटा सेंट्रल स्कोटोमा इज सीन इन, अभी तो किया था, ऑप्टिक नेराइटिस इन अ सेंट्रल स्कार. ओके, इनके सेंट्रल स्कार. बेटा एच वेच छोड़ दो, डोंट गो फॉर एच, जस्ट रिमेंबर व्हाट आई हैव टोल्ड यू. ओके, करेक्ट. चलो, सो विद दिस वी कम टू द एंड ऑफ न्यूरोप्था. ठीक है, 10 minutes wasted because of I wanted to finish by 8:30. 10 minutes wasted because of relogging, rejoining. I hope my voice is okay now. ठीक है, it started with a vocal nodule and it has become crackling. Okay. एमसीए का एक बार, एमसीए का बेटा उल्टा डी बनेगा. ओके, उल्टा डी बनेगा. ठीक है, चलो. साइड इज ऑपोजिट टू फील्ड इफेक्ट. यस, साइड इज ऑपोजिट टू द फील्ड इफेक्ट. करेक्ट. बेटा 7 minutes are very, very important in exam. Okay, if you're giving an exam, 7 minutes are very important. Dr. Sangya, I'm trying to drink and making sure that my voice remains okay. Hutchinson seen not in uncle herniation. Hutchinson seen in head trauma because of the increase in the intracranial pressure. बेटा अंकल herniation में तो आपका अंकल हो जाएगा. You will become an uncle. ठीक है, if uncle herniation happens, okay. Yeah, network. I have switched off my son's. My son was watching some cartoon show. I was switched it off. ठीक है, I hope it is not because of that. चलो, let us start with squint. ठीक है, now we are moving on to third, fourth and sixth nerve. Third, fourth and sixth nerve, which is there. अरे poor guy नहीं है. He is not a poor guy. ठीक है, चलो. Now let us start with extraocular muscles. By no means his dad is, he is reading Rich Dad Poor Dad. ठीक है, he is in class, he is in school बेटा अभी तो. Rich Dad Poor Dad. I'll show you his book after the during the lunch dinner break. I'll show you his book. He's reading Rich Dad Poor Dad. ठीक है. So let's start their actions. Sixth nerve palsy, third nerve, fourth nerve, squint and types of squint. Okay. How many extraocular muscles? There are 7 extraocular muscles. 1 for lid, 1 for lid, and 6 for eyeball. 6 for eyeball. ठीक है. Please remember the mnemonics. SO4, LR6, rest all third. ठीक है. Next mnemonic is SYN and RAD. SYN and RAD. Superiors are intorters. Recti are adductors. Recti are adductors. And obliques are abductors. ठीक है, obliques are abductors. Obliques are abductors. So if you see, obliques are abductors, recti are adductors, mid-rectal adductors have adduction, abduction. They do not have any secondary and tertiary action. Thus, everything can be deciphered from this. One very good mnemonic is solid. One very good mnemonic is solid. Solid is superior oblique, okay, causes lateral intorsion and depression. Okay. solid, lateral intorsion, and depression. Various MCQs that can be asked. Correct? Okay. I hope you can remember these. Next, we come to yoke muscles. What are yoke muscles? Yoke muscles are pair of muscles between two eyes, okay, responsible for a particular gaze. Responsible for a gaze. Okay, responsible for a gaze. Voice cracks. Voice cracks. इस चैप्टर से बहुत दुनिया नहीं बेटा, दुनिया बर्बाद नहीं है। चलो, थैंक यू, थैंक यू, थैंक यू, आ जाओ। ऑल फाइन बेटा, अब तो उसका वही बंद कर दिया। जियो वाईफाई नहीं है, एयरटेल का वाईफाई यार, अच्छा वाईफाई लगाया है वैसे। कल तो ठीक था यार, सेम वाईफाई। आई I wanted to change wife, but I've not changed the Wi-Fi. Definitely वाइफ तो चेंज कर लेता, वाईफाई कभी चेंज नहीं करता ना। अच्छा, so medial rectus and lateral rectus is a pair of yoke muscles. Okay, medial rectus and lateral rectus is also a pair of yoke muscles. Now, how to remember the other pairs? Okay, it is very easy to remember the horizontal pairs, medial rectus and lateral rectus. Very, very simple. Talking about right inferior oblique. Okay, then the pair of yoke muscle is left superior rectus. Just reverse all three. Okay, reverse all three. Okay, the mnemonic is reverse all three. So right becomes left, inferior becomes superior, and oblique becomes rectus. Okay, right becomes left, inferior becomes superior, and oblique becomes rectus. Okay, you have to just reverse all three. So if the patient is looking like this, if the patient is looking like this, okay, then this eye, right inferior oblique is acting, and this eye, left superior rectus is acting. This is the pair of yoke muscles. Okay, this is the pair of yoke muscles. Let us say patient is looking like this and looking here. Patient is looking like this and looking here. Both the eyes are looking here. Okay. Then what is happening? See here, right inferior rectus. If they ask you what is the yoke muscle of right inferior rectus, so then right will become left, inferior will become superior, rectus will become oblique. So see here, left superior oblique. Okay, left superior oblique. This is how you can find the pair of yoke muscles. Okay, this is how you can find the pair of yoke muscles. Understood? Correct. Now, let us move to, is yoke muscle clear to you? Good. Now we move to the various palsies, sixth, third, and fourth canal palsy. Sixth palsy. As you can see, can you appreciate that this eye, when this eye has gone in, this eye has not moved. This is the yoke. This is the failure of abduction. Failure of abduction. So sixth nerve supplies the lateral rectus, which is responsible for abduction. Okay. So in sixth cerebral palsy, abduction is affected. Abduction is affected. Lateral rectus, abduction is affected. Okay. Correct. Understood. So the patient will present with diplopia. Patient presents with diplopia. Okay, Dr. Harshit, for you. Patient presents with diplopia. What is the other feature the patient present? What is the other feature? Yes, absolutely good, Dermadoc. Face turn. Face turn. The face will turn. Okay, we do not show head turn. It is the face. The face turn. It is called as face turn. Okay, that is a compensatory head position. Okay, it is a compensatory face turn towards the side of paralyzed muscle. This is basically, remember, whatever action muscle is not able to do, muscle is not doing, will now be done by the neck, will now be done by the neck. Whatever action muscle is not doing will now be done by the neck. Simple, very simple. Okay. Whatever you will not do, your HOD will have to do. Very simple. So if you want to harass your HOD, you can stop doing the game. Okay. Correct. So, so double vision, esotropia, limitation abduction, normal abduction, and compensatory pattern. Okay. Very good. Now, next, third nerve pedulas. Thank you, Dr. Varma. Now, see here. Appreciate this. In every pic, you will see this thumb. In every pic, you will see this thumb. And only in this, you are not seeing the thumb. So, how does the patient present? How does the patient present? With ptosis. Patient presents with ptosis. Okay. That is the primary complaint with which the patient presents. Okay. Patient will not present with diplopia because the eye is closed. Okay. Now, after lifting, after lifting, see the position of eyeball. Even when the patient is looking up, the eyeball is down. Okay. Even when the patient is looking up, the eyeball is down. Eyeball is down. Eyeball is down in all cases. Even when the patient is looking up, the eyeball is down. So the eyeball is down and out. The eyeball is down and out. Why? Down and out. Out because of lateral rectus, down because of the superior oblique. Okay, this is MCQ because superior oblique and lateral rectus are working. This is how the patient presents. This is the third killer palsy. Okay, patient presents with ptosis, eyeball is down and out, down and out. Pupil is involved, pupil is involved. Okay, pupil is dilated. Pupil sparing third nerve palsy. Pupil sparing third cranial palsy is seen in diabetes, hypertension, the microvascular diseases. The microvascular diseases will lead to pupil sparing third nerve palsy. Okay, yes. Okay, understood this. Correct. Patient presents with ptosis and eyeball down and out. Correct. Next, which is not a feature of third cranial palsy, which is not a feature of third cranial palsy. Pupil dilation with the ptosis down and out, and abduction limitation is not a feature. Abduction limitation is not a feature of third cranial palsy. Remember this. Correct. Okay. Fourth cranial nerve is basically trochlear nerve, which is what is this? What is this supplying? Which is it supplying? Fourth cranial nerve is supplying. Yes, superior oblique. Superior oblique. What is the primary action of superior oblique? What is the primary action of superior oblique? Intorsion. 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 Okay. Please remember this. Uh, in this, where is it? In this, see here. Please remember, please focus on this part only. Please focus on this part only. See here. All the muscles have a separate primary action. There is no overlapping of primary action. Medial rectus is causing adduction. There is no adduction anywhere else. Okay. So oblique primary action is torsion. It is not there in any other. So primary action of every muscle is separate. Please remember this. Primary action of every muscle is separate. So superior oblique causes encyclotorsion, even though superior rectus also causes, but it is not the primary action. Okay, it is not the primary action. So synergistic is something which will add on. So see here, for intorsion, superior oblique is the primary muscle. Superior rectus is the synergistic muscle, which is adding, which is saying, okay, I will help you. That is what is synergistic. Okay, correct. Have you understood what is synergistic? It is something which will add. So superior oblique is the eyeball causing intorsion. So in case intorsion is not there, what is intorsion? What is intorsion? See, intorsion is turning the eye in. If the eye is not turning in, what will happen to the head? Head will turn to that side. See, think, just give 1 minute, just give 1 minute to this. Eye is not going in. And sir had told whatever eye is not doing will now be done by the neck. So eye has to go here. Eye is not going. So head will go here. Okay. So head goes to which shoulder? Opposite shoulder. Head goes to which shoulder? Opposite shoulder. Very easy to understand. The whatever action the eye is not doing will be done by the neck. Okay. So if this is not happening, the head goes to. If you turn head to the same side, then problem. Then patient sees double. Okay, correct, understood. So see here. So this is the eye which is vected. So head goes to opposite shoulder. If you take the head to the same shoulder, then there is, see here, one eye has gone up, the other eye is remaining in the center. Okay, one eye has gone up, the other eye in the center. Now, beta, sixth nerve. So sixth nerve is here. So head will turn to this side, the same side. Yes. ठीक है, Dr. Manik Biswas, absolutely good. But not, we do not call it a shoulder, we say same side, beta. ठीक है, Dr. Biswas? Is that okay? Correct. So asymptomatic diplopia is vertical, head to the opposite side, hypertropia on the affected side. Because why hypertropia? Because one is intorsion, second is depression. So depression is not there. So eyeball goes into hypertropia. Okay. Eyeball goes to hypertropia. Okay. Correct. This is what is Bill-Shawski test. This is Bill-Shawski test. Compensatory head position. So there. And if you turn to the same side, then hypertropia is worse. This is Bill-Shawski positive. This is Bill-Shawski test positive. Okay. Remember this Bill-Shawski test, which is for the fourth cranial palsy. Correct. Understood. Is this okay? Third, fourth, sixth palsy, okay. Let us move to three grades of binocular single vision. This is grade 1, grade 2, and grade 3. Grade 1 is simultaneous macular perception. Simultaneous macular perception. Grade 2 is fusion. Grade 3 is stereopsis. But a Park three-step test is basically to identify the paralyzed muscle. Okay. For understanding the three-step test, we need more time. Maybe tomorrow I'll post a question and tomorrow we'll solve that question and understand the Park three-step test. Okay, beta? Today it is not possible to cover in the class, but tomorrow I'll definitely post a question on Park three-step test and we'll do that. Okay, is that okay? Okay. Now, for evaluation of squint, we need to do these tests. Clinical evaluation of squint is done by these tests, which is Hirschberg test. MCQ. What does the Hirschberg test is based on which image? Hirschberg test is based on which image? Which image? Purkinje image. Yes, first Purkinje image. It is based on the first Purkinje image. Okay, one MCQ. Second MCQ. 1 millimeter of deviation indicates how much variation. Achha, we'll do that. Chalo. Maddox rod, Maddox wing, Hess chart, Lee screen, Worth dot test, backgrounded. We'll do all these tests. Okay. So this is how the Hirschberg test looks like. This is how the Hirschberg test looks like. Are you able to appreciate this reflection? This reflection of the torchlight? This is there. Okay. Yes. 1 millimeter of deviation is 15 diopters or 7 degree squint. 7 degree squint. 2 millimeter is 30 diopter or 15-degree squint. 3 millimeter is 30-degree squint, and 4 millimeter is 45-degree squint. This is also called as at the pupil border, okay, in the middle, and this is at the limbus. This is at the limbus, okay. 15-degree, 30-degree, and 45-degree squint. In diopters, it is double. In diopters, it is double the degree. Okay, correct. Next is Maddox rod test. Maddox rod test. Okay. What is Maddox rod made up of? It is made up of parallel arranged cylinders. Parallel arranged cylinders. Okay. What does it do? What does it do? It converts a dot signal to a line. It converts a dot signal to a line. Okay. So when you put a dot to the patient, with one eye the patient is seeing the dot. With this eye, the patient is seeing the dot. With this eye, the patient is seeing the line. Okay. In case of no squint, the patient will see line, and in the center, the patient will see the dot. Okay. In case of in case this is gone out, see if this is gone out, then the line is out and dot is here. In case this eye has gone in, then the dot is here in the center and the line has gone in. Okay, this is ISO. Okay. In case of hyper and hypo, if you want to do hyper and hypo, you will have to turn this rod to like this. You will have to turn the rod to like this. Then the patient will see, you will turn the rod to like this. Patient will see a horizontal line like this. And with this, the patient will see the dot. Okay, with a dot astral cortex, patient will see like this. In case there is no squint, okay, in case there is no squint, the patient will see like this. In case of hyper, the eye has gone up. So there is up and there is dot. In case of hypo, you will see the dot is there and the line is here. In case of hypo, it is there. Okay, this is correct. You have to turn the Maddox rod. You do it like that. This is Maddox rod test. Okay, Maddox wing test. Next is Maddox wing test. With this, one eye sees the scale. Okay, one eye sees the scale. Okay, the other eye sees the arrows. Other eye sees the arrows. Okay, so these are the various arrows. Like here, these are the various arrows. This arrow is for like this, moving like this. This arrow is moving for vertical, horizontal, and this arrow is for vertical, moving like this and this. Okay, so in cyclotorsion, excyclotortion, this is for horizontal squint. This arrow is for your vertical squint. You ask the patient to match the number and you have to move. Okay, so in this, one eye will see the scale, the other eye will see the arrows. The patient has to move. Okay, correct, and bring them in the center. So you can measure how much squint is there. Examination Hess chart. Is Maddox rod and Maddox wing clear to you? Is Maddox rod and Maddox wing clear to you? Hyper and hypo. In Maddox line is reflex right. Beta Dr. Shri Lakshmi, what is the problem, beta? It is very, very simple, beta. It is very simple. In Maddox rod, it is converting the light. See, you have put the rod here, and with this eye, the patient is seeing the dot. With this eye, because the rod is there, the dot will appear like a line. Okay, I am seeing at the dot. See, I am seeing at the camera. So there is here. So with this eye, I will see only dot. With this eye, I will see the line. In case my two eyes are aligned, I will see a line and a dot in the center. In case this eye is gone out, so with this eye, the line will appear here, the dot will appear here. In case this eye has gone in, okay, the line will appear here, the dot will remain in the center. Okay, this is how it is there. Okay, Maddox rod, okay. Maddox wing. Maddox wing. I have put a barrier here. See this? See this? Can you see this? Can you see this? Can you see this? This is a barrier. Okay, this is a barrier. So from one side, I am seeing only the arrows. With the other side, I am seeing only the scale. Okay, I have to move the arrows to make sure that I match the scale and the arrows. Okay, where do I match the scale and the arrows? I can come to know whether there is a vertical squint, whether there is a horizontal squint, or whether there is a turn squint. Okay, you see this. Okay, this is what is Maddox wing, and Maddox rod is this. Understood, beta? Maddox rod and Maddox wing. Very simple, beta. Okay, correct. Hess chart and Lee screen. Again, the same method, same thing. Again, the same thing. You have to see the child is standing here and there is a mirror here. There is a mirror here. Okay. And with the mirror, the child is seeing this chart and child is drawing on this chart. So with one eye, I am seeing the diagram and I'm drawing the diagram. Okay, with my so the child is drawing the diagram. Examiner is showing what to draw. Okay, this is how Hess chart and Lee screen is there. Okay, and you come to know which muscle is paralyzed. Can you appreciate medial rectus, lateral rectus, superior rectus, inferior rectus, superior oblique, inferior oblique? Okay, so which one is teda? You can identify the paralyzed muscle. Okay, so you have to find the peritic deviation. Hess chart and Lee screen. Okay, so this is the Lee screen, which will give you a Hess chart. Which will give you a Hess chart. Okay, correct. So this is the to identify the paralyzed muscle. Okay, correct. These are simple if you just think how it is being done. Correct. Okay. Yes, you have to see with one eye and you have to draw with the other eye. Absolutely good, Dr. Arunav. Absolutely good. Correct. Now, Worth 4 dot test. Worth 4 dot test. MCQ has come on this. MCQ has come on this. See, red glass in right eye. So R. Red glass in front of the right eye. Okay. Green glass in front of the left eye. So patient is wearing glasses like this, red and green. And this is what the patient is shown. Okay. If both eye are working good, patient will see only 4. Okay. If both eye are working good, both good, patient will see 4 dots. Patient will see 4 dots. Okay. Now, if right is suppressed, if the right is not working, right is suppressed, right is not working, then what will patient see? What will patient see? Right is not working. Yes, patient will see 3 green. Absolutely good. This will appear as green. Okay. If left is not working, if left is not working, then patient will see what? Yes, 2 red. Absolutely good. If there is diplopia, if there is diplopia, that the one eye is here, one eye is here, both are seeing, but the eyes are deviated, eyes are separated. Yes, patient will see 5 dots, and that is 3 green and 2 red. 3 green and 2 red. Absolutely good. Is this okay? Have you understood this? This is how word 4 dot test is there. It's correct. Okay, correct. Very good. Good man, the Lalten. Very good. Adam. This is striated glasses. This is just like Maddox rod. In Maddox rod, just like Maddox rod. See here. See here. So you have rods like this. Patient will see a line like this. You have rods like this. Patient will see a line like this. Okay. So in case patient is normal, in case the patient is normal, patient will see like this. In case patient has diplopia, then the patient will see like this. Okay. Normal will see like this. Correct? Understood? See here. This is the normal. This is the normal. Okay. Diplopia is this. Double is this. Suppression. Suppression is one eye is not working. Okay. And scotoma, that is center part is lost. That is scotoma. Center part is lost. That is scotoma. Okay. Correct. बेटा डिप्लोपिया इसके अंदर था. The two eyes are working separately. This red and this red. So the patient will see two red. With the other eye, with the left eye, with the other eye, patient will see this green, and this green. Okay, correct. मुझे ना now I am thinking lag is लग गई. ठीक है. Whenever you write lag ना, I feel like लग गई. अब फिर लग गई. ठीक है. करेक्ट. तो when ठीक है. Can't hear the whole sentence. यार यहाँ पे मुझे कुछ नहीं दिख रहा. बीच बीच में थोड़ा है. थोड़ा है, थोड़े की जरूरत है. I think what I'll do is when we take a dinner break, I will switch off my Wi-Fi and switch it on again. ठीक है. तब दोबारा वही करना पड़ेगा. ठीक है. चल. Yes. Titmus test. This is adjustable. Thank you for adjusting. Thank you for Buy Jio. ठीक है. जियो मेरे लाल, मैं जियो भी खरीद लेता हूँ. कर दूंगा. नया ले लो. नया ही लगवाया था जी. अभी नया ही लिया था जी. पर नए में ही गड़बड़ हो गई जी. क्या करें जी. हैं. चलो आ जाओ. टिटमस टेस्ट इज बेसिकली बेटा टॉप स्पीड अनलिमिटेड स्पीड वाला लिया हुआ है. ठीक है. चलेगा तो एक ही. चलेगा तो एक ही. चलो. टाइप्स एंड ट्रीटमेंट ऑफ स्क्विंट. सी. apparent squint is also called as pseudo strabismus. Pseudo-strabismus, okay, seen with a broad nasal bridge, seen with a broad nasal bridge, okay, broad nasal bridge. Latent squint is called as phoria, manifest squint is called as tropia. Manifest is tropia, latent is phoria, which is there. Correct. Comitant and incomitant. Comitant is constant. Comitant is constant. Incomitant is inconsistent. Inconstant या inconsistent. अभी करता हूं टिटमस टेस्ट. I'll do. ठीक है. Constant and inconsistent. Inconsistent can be paralytic or can be not paralytic, which is also called as restrictive. Restrictive. Either there is a restriction or there is a paralysis. These are the inconsistent squints. Okay. Concomitant. Comitant is also called as concomitant. Okay. Please remember this, that the amount, if one eye is straight, the other eye is straight up. No matter where you are looking, the difference is same. See, in case of a paralytic squint, what is happening? Let us say there is a sixth nerve palsy. Sixth nerve palsy. Okay. Then this eye is gone in. When the patient is looking this side, this eye mid rectus is good, this side lateral rectus is good, no squint. When the patient is looking straight, there is some squint. But when the patient is looking to the right, there is maximum squint. So the amount of squint varies in a paralytic and a restrictive squint. That is called as incomitant squint. Comitant squint is when wherever the patient looks, the amount of deviation between the two eyes is same. Understood? Okay, correct. Chalo. Esotropia. Eso is inward, tropia is paralysis. Esotropia. Yes, angle same in. Very good. It is eye is turned inward, reflex is not symmetric. Esotropia can be of two types. It can be accommodative or a non-accommodative type. Accommodative is because of near triad. Because of near triad. So whenever the patient accommodates, the eye converge leading to squint. Okay, leading to squint. So the treatment is refraction. Treatment is refraction under full cycloplegia. Under full cycloplegia. Refraction under full cycloplegia is the treatment for accommodative squint. Yes, it is more commonly seen in hypermetropes. It is seen in more common in hypermetropes. So, hypermetropia. Okay. Non-accommodative is the different type which is there. One is a essential infantile accommodate esotropia. One is essential infantile esotropia or congenital esotropia. Okay, what is this? This is child presents within 6 months. Child presents within 6 months of birth with esotropia. Child presents within 6 months of birth with esotropia. It's a large angle squint. Please remember, it's a large angle squint. It's a large angle squint. Okay. What is the next important point? It's a large angle squint. What? Hyper. It's not defective. Yes. The last one. What is the refractive error? There is very important point. There is no refractive error. There is no refractive error. Okay. There is no refractive error. Okay. And the patient has cross fixation. Patient has cross fixation, which means to look to right, to look to right side, patient uses left eye. Patient uses left eye. When the eye is gone in, so the eye has gone in, patient is using the right eye to look to the left, and patient is using left eye to look to the right. So this is what is cross fixation. Understood what is cross fixation? This is there. Okay. And treatment is surgery. And treatment is surgery. Treatment is surgery. Okay. Correct. Understood. So, is essential infantile esotropia or congenital esotropia clear to you? Is congenital esotropia or essential infantile esotropia clear? Okay. Good. Chalo. Thank you. Cross fixation, beta. Cross. Understand. Just think. When the patient is looking to the left, what do? You turn both the eyes to the left. Here the eyes are like this. So patient uses right eye to look to left and left eye to look to the right. Correct? Chalo. Incompetent squint. Incompetent is varying degree of squint in different directions of gaze. It is of two types, paralytic and restrictive squint. Okay, good. Paralysis. We have done this. We have done this. Third, fourth, sixth palsy. Okay, this we have done. Restrictive squint. Restrictive squint is because of restriction. Okay, restriction is entrapment. Thank you. Is entrapment. Okay, entrapment of inferior rectus, as in blow out fracture. As in blow out fracture. What is the other example? What is the other example? Thyroid disease. Thyroid disease. Okay, thyroid disease. Yes, very good. Okay. So this is how to differentiate between these two. How to differentiate? It is forced duction test. Forced duction test, FDT. What is force reduction test? In force reduction test, you put, you numb the eye with topical anesthesia, with topical anesthesia. Okay. Then the examiner, without the patient moving, examiner moves the eye with forceps. Okay. So when you put anesthesia, examiner is holding the eyeball with the forceps and is moving the eye. If the eye is moving, it is paralysis. If the eye is not going up, it is trapped. It is restricted. So to differentiate between a paralytic squint and a restricted squint, you do a forced induction test. You are using force to move the eye. Okay, so examiner is using forceps to move the eye. Okay, correct. Now, very important is clinical features of paralytic squint. It is usually it is usually sudden in onset. It is usually, yes, FDT positive is restrictive. Yes, absolutely good. Post-restriction test positive means restriction. Okay. Now, paralytic squint is sudden in onset. Sudden in onset. Okay. Patient presents with diplopia. There is confusion, headache, nausea, vomiting. Okay. Nausea, vomiting. Yes. Vertigo. Okay. And a very important feature is compensatory head position. Compensatory head position. Okay. Compensatory head position. Okay. Correct. Is it okay? This is what is how you differentiate paralytic and restricted. So paralytic squint we're done. Oculomotor, trochlear, abducent. Total is all three combined. Total internuclear ophthalmoplegia. What is ophthalmo? What is plegia? Plegia is paralysis. Ophthalmo is eyeball. What do you mean by internuclear? What do you mean by internuclear? Dr. Anindita, this is for you, beta. What is internuclear? For understanding internuclear, we need to understand that when the patient is looking to one eye, one side, right side lateral rectus is contracting, and the other side medial rectus is moving. When both eyes are moving, supply of lateral rectus is sixth nerve. Supply of medial rectus is third nerve. Third nerve and sixth nerve are two different nuclei. Where are they connected? Where are they connected? They are connected by the MLF, medial longitudinal fasciculus. Okay, so third nerve, sixth nerve, this is how the nerves are. Third nerve, sixth nerve, this is the eyeball. Eyeball has medial rectus, medial rectus, this is the lateral rectus, this is the third, this is the sixth. Sixth is supplying here. The other eye, this is the medial rectus, this is the lateral rectus. Okay, so this is the eyeball, this is the eyeball, okay, medial rectus and lateral rectus. So this is the third nerve supplying this side, and this is the sixth nerve supplying this side. Okay, now whenever the eye is going to move like this, when the eye is going to move like this, so this will send signal here. Okay, and this will give signal to this structure, which will give signal here, and this will give signal here to give the medial rectus. Okay, so this is where the lesion is. This is the MLF. MLF is medial longitudinal fasciculus, medial longitudinal fasciculus. Okay, MLF. Okay, so whenever the signal goes here, and at the same time the signal goes like this goes like this, and this goes like this. So whenever there is stimulus, it is there. Okay, so MLF, medial longitudinal fasciculus, which is affected. In case of the internuclear ophthalmoplegia, the lesion is here. Okay, understood what is internuclear ophthalmoplegia? Is this okay? Correct. Good. Understood internuclear ophthalmoplegia. Between the two nuclei, what is structure? Between the sixth and third nuclei. And please remember, same side adduction is absent. Same side adduction is absent. Okay. Other side, the abduction is dancing. Okay. This is MLF. Okay. Correct. So, talking about receptive squint, one is Duane's retraction syndrome, DRS. The main feature is retraction of the globe on attempted adduction. Okay. So, I always give the mnemonic in, may in, out, may out. So, when the eyeball is going in, it will go in. When the eyeball is going out, the eyeball will go out. Okay. And whenever the patient looks in, the eye goes in. Whenever the patient looks out, the eye goes out. Okay. This is there. So why it is happening? Why it is happening? Because of this co-contraction of the medial rectus and lateral rectus. Yes, this is an exception to this is an exception to Sherrington's law. This is an exception to Sherrington law. And this is what we tell in biology. Exceptions are there for everything. So here it is an exception of Sherrington law. When the medial rectus is contracting, lateral rectus should relax. But what happens here? When the medial rectus contracts, the lateral rectus also contracts. So when the patient medial rectus contracts, lateral rectus also contracts. So the eyeball is going in. When the medial rectus relax, when patient looking out, the medial rectus relax, lateral rectus also relax. The eyeball comes out. Okay, this is what is the Duane retraction syndrome. Okay, in may in, out may out. Okay, this is the feature of all three types. Okay, this is common in all three types. Please remember this. This is common in all three types. There are three types. Type 1, type 2, type 3. Limitation of abduction, limitation of adduction, limitation of both abduction and adduction. Please remember, count the D. How to remember 1, 2, 3? Count the D. So in abduction type 1, adduction type 2, both adduction and abduction type 3. Okay, correct. Sine qua non is basically your co-contraction. Okay, B comes first. You can remember B comes first. B comes first. You can remember like that also. Okay, this is Duane attraction syndrome. Duane attraction syndrome. Now coming to treatment of squint. Treatment of squint is by three methods. First is refractive error. Second is third is amblyopia, and surgical management is the last. Surgical management is the last. Please remember, this is first, second, third, and fourth. Correct. So eyeglasses, contacts, eye patch, prisms, and finally we come to surgery. Weakening procedure is recession. Strengthening procedure is dissection. No MCQ has come on this. Take care. There is not an MCQ, but you should be knowing. Okay. So muscles, types of squint, it's a paratrace, strip, diagnosis, and types of squint. Any questions you want to ask? Any question? I hope squint is clear to you. Okay. Good. Is that okay? Okay. With this, we cover 2 units and we'll take a break. Okay. I'm live here. Now we'll go to the retina. Okay. Internuclear, beta. Internuclear is very simple, beta. Internuclear is very simple. This is medial rectus. Beta, consider medial rectus, lateral rectus, lateral rectus. Okay. There is a frontal eye field. Surgery for spin. I'll tell you. I'll give you. There is a frontal eye field, which is the gaze center. Okay. This gives signal. Okay. This gives signal to the sixth nerve. Okay. So if somebody is calling me, the signal is coming, the frontal eye field will get stimulated. Okay. It will give signal to the PPRF, pantine pararetical fibers. That is horizontal gaze center. PPRF. This is the horizontal gaze center. This is the horizontal gaze center. This horizontal gaze center will give signal to the sixth nerve. When the sixth nerve signal is given, it will stimulate the lateral rectus. Now, when the lateral rectus is stimulated, okay, sixth nerve will now give signal to the opposite side, MLF, medial longitudinal fasciculus. This MLF will give signal to the third cranial nerve. This will give signal to the third cranial nerve. Now, this will give signal here. Okay. If there is a lesion which is here, then the signal will not go here. So this is what is internuclear ophthalmoplegia. Okay. This is the internuclear ophthalmoplegia. Understood? Is that okay? Now, see, for concept understanding, you need to understand this concept very clearly. If I cover this eye, and I ask the patient to look here, will the patient be able to look? Will the patient be able to look? Yes, patient will be able to look because third nerve will stimulate the medial rectus. Understand, beta? Then it is not a gaze, na. It is not getting stimulated by the sixth nerve. Why? This pathway is intact. This pathway is intact. Okay. Only when this pathway is getting activated by the sixth nerve, then it is not working. So understand the gaze paralysis. Gaze is when both eyes are moving. But if you cover one eye and you ask the patient to look on one side, then the eye will go. But if you open both the eyes, okay, then it will not go. Take care. Correct. We are game break. Yes. Okay, this is the concept which is there. ये रहा. ठीक है. Part 3 steps we're doing tomorrow, beta. We're doing tomorrow. Dinner break. Yes, we'll take a dinner break, and I have to reboot the system also. Okay. So let us take a dinner break. 9:30 to 10. We'll come back in 10. ठीक है. 1.5 फिर कल करेंगे बेटा. 1.5 कल करेंगे. आज नहीं हो पाएगा. We have to do retina and orbit and lot of things. ठीक है. Beta, Duane retraction syndrome is this. Duane retraction syndrome. Retraction. It is a retraction. So basically, whatever stimulus is going to the medial rectus, see here. Whatever stimulus is going to the medial rectus, innervating both medial rectus and lateral rectus. So third cranial nerve is innervating both medial rectus and lateral rectus. So third, when it stimulates the medial rectus to contract, the lateral rectus also contract. So the eyeball goes in. When the third nerve tells medial rectus to relax, the lateral rectus also relax. So both relax and the eyeball comes out. Okay. So that is why I've written इन में इन, आउट में आउट। ठीक है, इन में इन, आउट में आउट। ठीक है डॉक्टर तरार, इज दैट ओके? दिस इज कॉमन इन ऑल थ्री टाइप्स, दिस इज कॉमन इन ऑल थ्री टाइप्स। ठीक है, सो दिस इज व्हाट इज देयर, करेक्ट? सो टाइप वन abduction, टाइप टू adduction, टाइप थ्री बोथ adduction लिमिटेड। ओके गुड। INO बेटा अभी तो पढ़ाया, इंटरन्यूक्लियर ऑप्थैल्मोप्लाजिया। अभी आप जस्ट नाउ आई टोल्ड दिस इज INO, दिस इज द INO, इंटरन्यूक्लियर ऑप्थैल्मोप्लाजिया। ठीक है, let us take a dinner break. I'll reboot the system now, leaving the chat, leaving the class, and coming back in some time. Okay. Let's start. Everything is rebooted, and we are also rebooted after dinner. Dinner. Hey, hello, hello. Yes. Yeah, chalo, start. So we'll come to the retina. Retina is the neurosensory coat of the eye. Okay, we'll start with the retina. This is the neurosensory coat of the eye. Okay, correct. So this is what is the fundus view. This is what is the fundus view. This is the fundus. This is the macula. Macula is 5.5 millimeters. Okay. Fovea is 1.5 millimeters. Fovea is 1.5 millimeters. Inside the fovea is the foveola. Okay. Inside the fovea is the, so this is fovea. Then you have foveola. Okay. You have umbo in the absolutely center. Absolutely in the center is the umbo. Okay. There is a foveal avascular zone. MCQ can come on foveal avascular zone. How much is the size? It is 500 microns. It is 500 microns. Okay, 500 microns. 500 microns is this. Foveola is 350 microns. Okay, umbo is 150 microns. In microns. Okay, foveola is 350, umbo is 150. Foveal avascular zone is this. Fovea is 1.5 millimeters. These are the various size which can be asked. What is the size of the optic nerve? It is again 1.5 millimeters is the average, but it will vary from patient to patient. Myopes have a bigger optic nerve head and hypermetropes have a smaller optic nerve head. Okay. Please appreciate in this, the cup is this. This is the disc. Okay. You should be able to appreciate that there is a certain pink area. Okay. Certain pink area. In case you see the entire optic nerve as white, you don't see this pink area. Okay. You don't see a pink rim. Then it is called as optic atrophy. It is called as optic atrophy. Okay. If you don't see this cup and this disc, and in between, if you see the color here and see the color here, appreciate the color. There is a difference between the color. This is a neuroretinal rim. Okay. This is the neuroretinal rim. These are the retinal nerve fibers. These are the retinal nerve fibers. Okay, beta. If this part and this part A and part B are same, are white, then it is optic atrophy. Correct? Okay. Now, retinal layers we are done in the first chapter where we have done basics. Pigment epithelium, photoreceptor layer, outer membrane, outer nuclear, outer plexiform, inner plexiform, ganglion cell layer, nerve fiber layer, and the inner limiting membrane, ILM. This is how the 10 layers are there. Okay. And the inner nuclear layer has these Muller cells, bipolar cells, amacrine cells, and horizontal cells. These are the three cells which are there. This is a supporting cell. This is just for support. So the three cells are bipolar cells, amacrine cells, and horizontal cells. These are there in the inner nuclear layer. Outer nuclear layer is for rods and cones. The nuclei of the rods and cones. Okay, this is the outer nuclear layer. Ganglion cell layer is the cell. So there are three cells. One cell, two cell, and 3 cell. This is the receptor, this is the first order, and this is the second order as per Parsons. This I am quoting from Parsons, which is a standard textbook for undergraduates. This is I'm quoting from Parsons. Okay, correct. Very good. Next, these are the investigations. These are the various investigations. OCT scan is optical coherence, optical coherence tomography, optical coherence tomography. It is a light based test. Okay, it is a light based test. It is on light rays. There are no X-rays. There is no radiation. Okay, no X-rays. Please remember this. Okay, this is how a normal OCT looks like. The normal. This is an abnormal OCT. You can see the 10 layers of retina here, which is there. Okay, correct. These are the various. These are the. You can see the highlighted membrane. Highlighted membrane is the vitreous. It is the mevitreous. Okay, you can have a subretinal fluid. You can have intraretinal fluid. Now, fundus fluorescein angiography. Yesterday, when we were doing sodium fluorescein, so sodium fluorescein dye is injected into the which vein? MCQ. Which vein? Antecubital vein. Antecubital vein. Okay, antecubital vein. Okay, it is in the forearm, in the arm. Okay, in the elbow, at the elbow. Okay, you can also use the dorsum of the hand. You can also use the dorsum of the hand to give the dye. Okay, this is how a normal FFA looks like. Appreciate here the foveal avascular zone. It is appearing very dark. Can you appreciate this foveal avascular zone? It is appearing dark. This is the foveal avascular zone. There is no vascularity there. There is no blood vessels there. There are no blood vessels. Otherwise, everywhere else you will see the blood vessels. Okay, this is normal. This is normal. Okay, see here. See here. This is the patient with diabetic retinopathy. This is the NVE. Let me use a different color. This is how a NVE looks like. This is NVE. Okay. These small are microaneurysms. Microaneurysms. Okay. Microaneurysms. So this is how yes, new vascularization. This is how you can get MCQ based on this. There was an MCQ. How does the microaneurysm look like? It is a small leaky dot. It's a small leaky dot. Okay. Correct. Okay. This here, this picture here is denoting macular ischemia. Okay. This is denoting a macular ischemia. Okay. Macular ischemia. Okay. Correct. This is a macular ischemia. Okay. Let us talk about diabetic retinopathy. Diabetic retinopathy, it's a microvascular disease. It's a microangiopathy, microvascular disease. Microangiopathy resulting in microaneurysm. Resulting in microaneurysm. Okay, microaneurysm. Okay, correct. So microangiopathy resulting in ischemia, causing AV shunt and neovascularization. Diabetic is classified by ETDRS. What is ETDRS? What is ETDRS? Early treatment diabetic retinopathy study. Early treatment diabetic retinopathy study. हाँ बेटा, it looks like similar to Dr. Ronak. Absolutely right, beta. But you have to understand that in case of a diabetic patient where there is so much of leaking happening, if you see this, then you do not call it foveal avascular zone. It is macular ischemia. Okay. In this scenario, the patient will have a very poor prognosis. Okay, the patient will have a very poor prognosis. ETDRS classified diabetic retinopathy into non-proliferative and proliferative. Non-proliferative and proliferative. Non-proliferative is further classified as mild, moderate, severe, and very severe. Mild, moderate, severe, and very severe. Severe, very severe is further classified based on HVI, and we have to remember 4 to 1. Anil Kapoor, 1 2 ka 4, 4 2 ka 1. Okay. H is hemorrhages. Hemorrhages in 4 quadrants. Okay. V is venous changes. Venous changes in 2 quadrants. I is Irma in 1 quadrant. Okay. I is one Irma in 1 quadrant. Okay. But I was telling that, see here, somebody was saying, ki sir, this and this appear to be same. Okay. To that person I was telling, to that doc I was telling, ki beta ji, in case of so much of leaking, if you see a dark area, then it is not normal. ठीक है? If in case of a normal retina, you see a dark area, then it is foveal avascular zone. But in case of a leaking, it becomes ischemia. It is a macular ischemia. ठीक है? Okay, this is what I was saying. Now, ठीक है? So, 4 quadrant hemorrhages, 1 quadrant irma, 2 quadrant venous bleeding. If any one is out of these three, any one is present, it is severe. If any two are present, then it is very severe. Out of these three, if any one is present, then it is severe. If any two, then it is very severe. This is how you classify your mild, moderate, severe, very severe, non-proliferative diabetic. MCQ, proliferative. Proliferative, the hallmark is new vessel formation. New vessel formation, that is neovascularization. Neovascularization. And neovascularization are leaky vessels, so they will lead to hemorrhage. Which hemorrhage? Vitreous hemorrhage. They will lead to vitreous hemorrhage. Okay, correct. Is this okay? So this is how the non-proliferative and look like microorganisms in hard exudate, soft exudate, intraretinal hemorrhages. These are various things, and these are the venous changes in the form of beading, looping, and segmentation. See, can you see? It is looking like a sausage, looking like a sausage. Okay, see, sausage kind appearance, sausage-like appearance. This is segmentation. Looping is this loop. Okay. Beading is like beads. Beading is like beads. See here. These are the beads. Beading, looping, segmentation. These are the venous changes. Intraretinal microvascular abnormality, IRMA, is basically microvascular shunts. These are microvascular shunts. These are small, very, very small vessels between the capillaries. Between the capillaries. Okay. Okay. That is why they are given us special name. Okay. These are IRMAs. Okay. So basically, non-proliferative and proliferative. Proliferative is, see here, new vessels are forming. Okay. Normal vessels are like this, straight. Okay. They are straight. But see here, cabbage-like vessel, a frond of vessels. Okay. This is what is PDR, a frond of vessels and hemorrhages. Okay. And these are otherwise hard exudates, soft exudates. Okay. Cotton wool spots. These are cotton wool spots. Okay. These are cotton wool spots. Okay. Lipid are hard exudates. Yes. Lipids are hard exudates. Very good. On fluorescent angiography, you can see NVE, and this is our NVE with FFA looks like. This can come as an MCQ, as an image-based MCQ. It can come like this. What is NVE? Soft ischemia. Yes. Soft ischemia. Soft is also called as cotton wool spot. Soft exudate is also called as cotton wool spot. They are because of nerve fiber layer ischemia. NVE, neovascularization elsewhere. Elsewhere. Okay. NVD. Okay. That is neovascularization at disc. At disc. Okay. NVD is a poorer prognosis. NVD has poorer prognosis than NVE. Okay, than NVE. Okay, NVD has poorer prognosis than NVE. Please remember this, very, very important. Okay, MCQ, INICT number 23, which the following is not seen in very severe. Not seen in very severe. Yes, it is not seen in very severe. It is seen in, it's seen in not NPDR, it is seen in a feature of PDR. It's a feature of PDR. Very good. Understood. So this is how it is: microvascular occlusion, non-perfusion, tissue hypoxia, release of VEGF, new vessels. You can have NVD, NVE. This is in the retina. This is happening in the retina. NVA and NVI, these are the features in the anterior segment. Anterior segment, that is at the angle and at the iris. At the angle of anterior chamber, okay, at the angle and at the iris, which is there, is the anterior segment. Okay. NVT, NVE. So let us talk about first the retinal. First, we'll talk about the NVT and NVE. NVT, NVE will lead to hemorrhages. I was telling you, the vitreous hemorrhage. If we do traction on the retina, traction RD, and drigma whole forms, then it becomes a combined RD. This is the NVT, the end result of NVT, NVA. What is the end result of NVA, NVI? It leads to neovascular glaucoma. Remember, rubeosis iritis, rubeosis iritis. We are done in glaucoma. Okay. First, it's an open angle, then angle closure, optic atrophy, and absolute eye. This is how. MCQ. Where in the iris you first see the new vessel formation. In case of NVI, in NVI, new vessels are seen first at new vessels are seen first at pupil margin. Yes, at the pupil margin. Okay. Then at the angle. Then at the angle. To see these new vessels, you have to do a gonioscopy. You have to do a gonioscopy. Only then you will be able to see these new vessels. But the first new vessels, they happen at the pupil margin. Okay, at the pupil margin. But the NVA is neovascularization at angle. NVA, I was telling you, is neovascularization at angle. At angle. Okay, correct? Good. So, what is the MCQ? What is the risk factor of diabetes? Duration of diabetes is the most important. Poor metabolic control is less important. HbA1c has an increased risk. Increase in HbA1c has increased risk. Okay, correct. Okay, चलें. ठीक है. Screening for diabetes. First, type 1 diabetes. First is at 5 years from onset. At 5 years from onset. Type 2, immediately. Immediately at diagnosis. Immediately at diagnosis. Gestational in every trimester, gestational in every trimester. Okay. Follow-up examination. Okay. Depends on depends on stage of diabetic retinopathy, stage of retinopathy, and on metabolic control and on metabolic control. ठीक है on metabolic control. If the patient has proliferative stage, you will follow the patient every 2 weekly. ठीक है. If the patient has only one aneurysm, ठीक है, patient has diabetes since 20 years, patient is maintaining HbA1c as 5.7, okay, go home, come once in a year. Okay, go home and come once in a year. Okay. नहीं. First is stage or activity. First is the stage. At what stage the patient is presenting? What is the level? Okay. Second is metabolic control. ठीक है. Correct है. Either the most important is duration of diabetes. ठीक है. Poor metabolic control is secondary. Okay. Proliferative, we have newest question treatment is laser photocoagulation. What is laser photocoagulation? Which laser is used? MCQ. Which laser is used? It is double frequency and diag. Double frequency and diag. What is the wavelength? Yes, 532 nanometers. Okay. What do you do with the laser? You do a PRP as is shown in the diagram. This diagram has come as an image-based question. This diagram has come as an image-based question. This is pan-retinal photocoagulation. What do you do in this? What is done? You convert ischemic retina to anoxic. ठीक है. Ischemic retina to anoxic. You are going to kill the retina. ठीक है. You're going to kill the retina. ठीक है. MCQ. Which layer of retina is lasered? Which layer of retina is lasered? Which layer of retina is lasered? Pigment epithelium. Very good. Retinal pigment epithelium. Okay. MCQ. Which layer is most resistant to laser? Which layer is most resistant to laser? Ganglion cell layer. Ganglion cell layer, beta. Very good, Dr. Anukriti. So, ganglion cell layer. Okay. MCQ. What is the side effect of PRP? What is the side effect of PRP? What will obviously happen with PRP? Tunnel vision. Very good. Tunnel vision. Tunnel vision. Okay. This is the side effect of PRP. What is happening here? See, in this diagram, only this much retina will be saved. Rest all the retina will be killed. If the retina is killed, patient will not be able to see. Patient will not be. So patient is seeing only in the center. But this is important to save this vision. Otherwise, this will also be lost. Okay. Side effect of PRP is tunnel vision. Okay. Correct. Or you can also remember, it can come in a separate way also. Loss of visual field. Loss of visual field. हाँ तरार शेख. हम लोग बोलते हैं वी कॉल इट एज बुकिंग योर लॉस. ठीक है. यू आर बेसिकली, है ना, जो दोज हु डील इन स्टॉक मार्केट्स, लॉस बुकिंग, है ना, बुक योर लॉस एंड चलो आगे. चलो. ठीक है. लेट अस टॉक अबाउट हाइपरटेंसिव रेटिनोपैथी. इज दैट ओके? Hypertensive retinopathy. What is the normal artery is to vein ratio? What is the normal artery is to vein ratio? It is 2:3. What is happening in hypertensive retinopathy? The AV ratio becomes 1:3. The AV ratio becomes 1:3 because there is arteriolar narrowing. Arteriolar narrowing. This narrowing leads to change in the shine. leads to change in the sign, because of which there is copper wiring, then there is silver wiring. Okay, copper wiring and silver wiring. Ganglion is radiocellulite. Yes. Okay, there is copper wiring and silver wiring. This is because of the change in the shine of the arterioles. Okay. There are superficial hemorrhages, heart exudate, cotton wool spots. These are seen. And we know Salu's sign is deflection. Salman Khan coming, I am shifting. Okay, you go. That is Salu sign. Bonnet sign is banking. Gun sign is tapering, which is there. Okay. Salu Bhai coming on bonnet, carrying a gun. My BP will rise. Okay. The reason for hypertension is Salman Khan is coming, sitting on the bonnet of a car, driving a car, and is bringing a gun. Okay, this is what is leading to hypertension. See here, it is all visible here. It's all. This artery was supposed to go like this. Sorry, this artery. This is the artery. Please remember, this is the artery. This is the vein. This is the vein. Okay, vein was supposed to go like this. Vein was supposed to go like this. See what has happened? Vein has gone like this. It is going like this. So this is deflection. It is deflected from its course. Okay. Second, are you able to appreciate that here it is narrow, here it is wide? This is narrowing. This is narrowing. Okay. This is narrowing. And this curve, and this curve. This is bonnet sign. This is bonnet sign. This curve is bonnet sign. So these are the three signs which are there. Deflection from the course, banking and narrowing, which is there. Correct? Understood? Reflex change, I've already told you. Copper wiring, silver wiring. What is normal AV ratio? This I have already. आर्टरी वेन को पहले पका और चोक चोक कर दिया. Yes, yes, चोक कर दिया. Absolutely right. Absolutely right. This is CRAO, central retinal artery occlusion. It's there. Correct. This is cherry red spot. Cherry red spot. Sudden onset. Sudden onset. Painless loss of vision. Sudden onset, painless loss of vision. Okay. It is a severe loss. It's a severe loss. Okay. But not total. Remember, it will not be total loss. Patient will not present with a blind eye. Patient will have perception of light, but it will be a very severe loss. Okay. Please understand this. Patient will not come with absolutely blind eye. He will have some sort of vision, some perception of light. Okay, please remember this. Now, what is the etiology? What is the etiology? What is the etiology? Thromboembolic phenomena. Okay, thromboembolism. Yes, thrombus. Okay, it is not. It is not coagulopathy. So there is no role of anticoagulants. There is no role of anticoagulants. Okay. बेटा पेनलेस है because पेनलेस है because retina has no pain receptors. Okay, retina has no pain receptors na beta. Pain is a feature which will be carried na, so there are no pain receptors in the retina. Okay, correct. So it's a painless loss of vision. Correct है? Yes, only sensory. चलो ठीक है. What are differential diagnosis of cherry red spot? B sting. B sting. Okay, this is Berlin's edema. Berlin's edema. What is the other name of Berlin's edema? What is the other name? Commotio retinae. Commotio retinae. Okay. This is sialodosis, sialodosis, Tay-Sachs, Tay-Sachs, ischemia. Ischemia is CRAO. Okay. Niemann-Pick, Niemann-Pick, and gangliosidosis type 1. Gangliosidosis Type 1. These are the various causes. Okay, correct, of the chariot spot. Treatment is massage, pressure, and sudden release. With sudden release, dislodge the embolus. Okay, resulting in the embolus going to where? Branch artery. Going to branch artery. Okay, going to branch artery. Beta, just now I told you anticoagulant is not effective. It is not a hemorrhagic. It is not hemorrhage. Okay. It is not, it is a thrombus which is coming. Okay, there is cianosis is a type of connective tissue disorder, beta. Okay. Please remember these things. Now, apart from this chariot spot, you can see cattle truck appearance. Okay. Hollen horse plaque, Hollen horse plaque. Okay. Cattle truck appearance, Holland horse plaque. What is the retinal ischemia time? What is the retinal ischemia time? It is 90 minutes. Yes, it is 90 minutes. Retinal ischemia time is 90 minutes. Okay. What is the prognosis? What is the prognosis of CRAO? Poor, very poor, beta. Prognosis of CRAO is very poor. Normally does not recover. Okay. It's a very poor prognosis. Take care. Let us come to CRVO. CRVO. See, this is a tomato splash appearance. Tomato splash appearance. Okay. Sauce and cheese appearance. Okay. Yes. Okay. Beta, optic atrophy because nerve fibers will be lost. Na, beta. Because of ischemia, nerve fibers will be lost. Okay. There is dilation of all branches, flame shimmer throughout all quadrants. Cottonwood spot, disc, and macular edema are common. The tomato splash appearance, as if there is, okay, this is CRVO. Okay, it can be of two types. CRVO can be of two types: ischemic and non-ischemic type. Ischemic type and non-ischemic type. Ischemic type leads to rubeosis iritis in a period of 90 to 100 days. 90 to 100 days. This is what is called as 90-day glaucoma or 100-day glaucoma. Okay? 90-day glaucoma or 100-day glaucoma. In case of ischemic type, when the new vessels are forming, we can give, we can give anti-VEGF injections. We can give anti-VEGF injections. What are the anti-VEGF injections? Bevacizumab, ranibizumab, brolucimab, brolucizumab. ठीक है. Bevacizumab is available by the trade name Avastin. Okay. This is Lucentis. ठीक है. This is Paganax. ठीक है. Yes, there is aflibercept also. Yes. Aflibercept. Okay, correct. Ischemic type has vision poorer than 6/18. Ischemic type has vision poorer than 6/18. Okay, correct. These are the various anti-VEGF injections. Now, see here, this question. In INSCT 24, presently committed superior feed loss for past 1 week. What is the probable cause of given condition? It is a branch retinal vein occlusion, BRVO. Okay. नहीं बेटा, BRAO will present immediately. ठीक है. BRAO will present sudden. Yes. ठीक है. BRAO is a very rare. ठीक है. It's a very rare presentation. Patient will not present. So BRVO is also same. But a CRVO will not have a superior field. In CRVO, there will be total field. There will be total field. Okay, Dr. Satvik. ठीक है, total field loss. Let us talk about age-related macular degeneration, ARMD. Why not A? Beta, because I'm telling you, na, patient will not give a history of 1 week. Patient will present with 1 day at least. Patient will present more faster. ठीक है. Second, mostly the occlusion in case of branches are venous occlusions. Venous occlusions are more common presentation in branch, ठीक है, rather than a artery branch occlusion. ठीक है, vein takes time. ठीक है, but a clinical feature is patient will present with blurring of vision in one eye. ठीक है, patient sees as hazy. When you examine the patient, patient will have this kind of fundus picture. Patient will have this kind of fundus picture. Otherwise, it's a painless sudden loss of vision. Again, it is painless sudden onset. ठीक है, blurring of vision. ठीक है, on OCT, yes, like CRA only, but the fundus picture is separate. The fundus picture is going to be different. Okay, correct. Next, talking about ARMD. This is age-related macular degeneration. Prognosis of CRVO will depend upon whether it is ischemic, whether it is non-ischemic. Non-ischemic has a better prognosis. Ischemic has a poorer prognosis than the non-ischemic type. Lekin still, ischemic has a better prognosis than CRAO. If you have to arrange in the terms of prognosis, then non-ischemic CRVO has best prognosis. Ischemic CRVO is second best. Most poor is CRAO. Okay, is that okay? Correct. Now, ARMD. Why it is happening? What is the reason for ARMD? See, beta, there is this pigment epithelium. There is pigment epithelium. Below the pigment epithelium is the Brooks membrane. This is the Brooks membrane. Behind the Brooks membrane are the vessels. These are the vessels of choroid. Now, the pigment epithelium, retinal pigment epithelium, takes the nutrition from these vessels. Okay, takes the nutrition from these vessels, and this is giving potty here and taking nutrition here. As the age passes, with age, some of the potty gets deposited here only. Okay, some gets deposited here only. Okay, and the retinal pigment epithelium gets lifted up. Okay, so because of deposition of this material, this is basically the byproducts, metabolic byproducts. Easy way to remember is potty, but otherwise these are metabolic byproducts. They get deposited, and this is what is called as drusen. And this is what is called as drusen. Okay, with time, the overlying pigment epithelium, this dies. As the pigment epithelium dies, it leads to atrophy of the retina. Okay, that is the with time. What happens is there happens a break in the Brooks membrane. There develops a break in the Brooks membrane, and through this break, the vessels they tend to grow. Okay, the choroidal vessels they will grow here. This is what is called as CNVM, choroidal neovascular membrane. This is what is a wet type, because new vessels are leaky vessels. So that is why wet type. So understood what is dry type and wet type? Understood why it is happening? So two types, non-exudative. Okay. There is a non-exudative. This is the dry type. Okay. Exudative is the wet form, which is because of choroidal new vessel formation, resulting in detachment of the pigment epithelium. Understood? So, dry type is the more common type, obviously, because everybody is developing this potty. Okay? So, there is drusen, deposition of material in the Brooks membrane, slowly atrophy of the pigment epithelium and photoreceptor over years. Over years. Is dry type clear to you? It is same as atrophic, dry, non-exudative, because there is no exudation. Okay? Huh. Yes, myopia can also run it. So this is how drusen looks like. This is the geographic atrophy looks like. These are the dry type of AMD. Dry AMD, age-related macular degeneration. Exudative is the lost common type. Vision losses fall because of exudative detachment of pigment epithelium. Choroidal neovascularization, they grow through defect in the Brooke membrane into the sub-RP space. Okay? Into the sub-RP space. Is this diagram? Remember this diagram better. If you'll remember this diagram, how this is happening, it will very easy to understand. It is very easy to understand. Okay, it get deposited. Deposit is called as D deposit, D drusen. Drusen results in pigment epithelium dies. Pigment epithelium dies. There is break in the Brooks membrane. Break in the Brooks membrane. Choroidal new vessel forms. New vessel forms. It leaks. That is a leaky vessel. It looks like this. It looks like, see, it looks like this. This is how the blood is leaking. The blood is leaking. Huh. So what is the risk factor? The most common risk factor is the most common if we talk about treatment and risk factor. So treatment, if we talk about treatment of AMD, talk about treatment is okay. Most important is stop smoking. Stop smoking. All of you who smoke, I know you are not listening, but stop smoking. So never, yes, never ever smoke. That is most important. Second is use of antioxidants. Start eating healthy. Start eating lot of green vegetables. Okay? Yes. By decreased UV product exposure, yes. Ultraviolet rays, UV exposure, that is there. That has to be decreased. But I'm very sure we doctors don't go out. Okay? Correct? बटर चिकन तो खाना पड़ेगा, उसमें एंटीऑक्सीडेंट होते हैं भाई. बटर चिकन हैज लॉट ऑफ एंटीऑक्सीडेंट्स. ठीक है. सो दिस इज फॉर प्रिवेंशन. दिस इज फॉर प्रिवेंशन. If it has happened, then what do? Use anti-VEGF injections. Again, because there are new vessels, na? There are new vessels. So use of anti-VEGF injections. Okay. Next important point is use of antioxidants. Start taking antioxidants. What are those? The newer antioxidants are lutein, zeaxanthin, astaxanthin. Okay. This has been given by ARED study. ARED study. Okay. This is ARED study. Okay. PDT is not being done anymore, beta. PDT was earlier being done. In PDT, we used to use vertiporfin dye. Okay. This vertiporfin binds with RBC with the blood, and now, okay. PDT is photodynamic therapy. PDT is photodynamic therapy. It is obsolete now. It is not being done anymore. We do not find any machines. ठीक है, PDTs. ठीक है, correct. Is that okay? Is treatment of AMD okay? ठीक है, correct. Now, retinitis pigmentosa, RP. Retinitis pigmentosa, RP. This is the triad of RP. Thin blood vessels, retinal pigmentation, and pale optic disc. ठीक है, pale optic disc. Okay, bony spicule. It is like a bony spicule. This is bony spicule pigmentation is there. Okay, it's a group of disorders. It's a group of disorders. Affects both rods and cones. Affects both rods and cones, but there are much more rods, so that is why rods are predominant. Okay, there are much more rods, that is why rods are predominant. So affecting loss of both photoreceptors. It is bilateral, defective dark cloudy night blindness, nyctalopia, starts in mid periphery. Starts in mid periphery. Okay, as you can you appreciate here that the bony spicules are in the periphery. They are not in the center. They are not in the center. Okay, so this disease starts in mid periphery. Okay, not in the extreme. Night blindness is an early feature, beta. Night blindness is an early feature. Let us see. No. Night blindness is an early feature, beta. Okay, very good question, Dr. P. Kennett. It's an early feature. In a disease, all forms of inheritance are known. Most common is sporadic. Sporadic means spontaneous onset, no family history. Spontaneous onset, no family history. That is the most common type. Amongst the inherited types, autosomal recessive is the most common. Dominant is the X-linked is least common, and worst prognosis. Worst prognosis. ठीक है, autosomal has best prognosis. Autosomal dominant has best prognosis. Okay, correct. Very good. Okay, so these are the various associations in the eye. There is a complicated cataract. We have done this. In complicated cataract, we are done. Okay, there is myopia, open glaucoma, keratoconus. These are the ocular association. Systemic associations are various syndromes. Various syndromes. Usher syndrome is basically retinitis pigmentosa plus deafness. RP plus deafness. ठीक है. Kern-Sayre syndrome. Kern-Sayre syndrome is a mitochondrial disease. Mitochondrial inheritance. Okay, retinitis pigmentosa plus heart defect plus CPO. This is a triad. Okay, RP plus heart defect plus CPO. This is the triad. Okay, Refsum disease is basically phytanic acid metabolism. Okay, Bardet Biedl is basically hypogonadism, obesity, polydactyly, retinitis pigmentosa is obviously there. Okay, these are the ways. Yes, moon phases. Hypogonadism will lead to moon phases. ठीक है, these are the various features. Okay, कर्ण की कहानी, ठीक है, वो क्लास में, ठीक है, we are doing revision. Basson Consvig is beta lipoprotein. ठीक है, absence of beta lipoprotein, mental retardation. ठीक है, who is कर्ण, महाभारत सुनो. ठीक है, A beta lipoproteinemia. So this is mental retardation plus growth retardation plus RP. Okay, this is the Passon-Kozlik syndrome. CPEO is beta chronic progressive external ophthalmoplegia. Chronic progressive external ophthalmoplegia. Okay, the entire eyeball becomes absolutely fixed. The lid also stops moving. The lid also stops moving. That is CPEO. Okay, there is no cure for RP. Vitamin A may slow the rate, but there is no cure for RP till date. We are trying gene therapy also, okay, but nothing, no fruitful results. Which the following statement is incorrect about ARG rod dystrophy con late presentation? No, it is not a late presentation. It's an early presentation. Oh, sorry. Late presentation, yani. Night blindness is not a late feature. Night blindness is a early feature. Okay, this is not, this is incorrect. Okay, this is incorrect. Okay, correct. Okay. This is our tunnel vision. This is our tunnel vision. Patient with RP will see this is the tunnel vision. Okay. Next is CME, cystoid macular edema. CME. Okay. It is because of central cyst. Okay. This is the cystic spaces. These are the cystic spaces. Okay. It can occur after pseudophakic or non-pseudophakic. Non-pseudophakic causes are diabetes, retinitis occlusion, CNVM. Pseudophakic is the Irwin gas syndrome, which we have already done. Irwin gas syndrome, which we have already done. This is because of inflammation. Because of inflammation. Okay. So the treatment is steroid. So one is test for choice is OCT. Test for choice is OCT. These are the cystic spaces. Okay. These are cystic spaces in which layer? In the Henle's layer. In the Henle's layer, which is the outer plexiform layer. Outer plexiform layer. Okay. But the Irwin gas syndrome is basically macular edema happening 4 to 6 weeks after cataract surgery. Whenever we are doing cataract surgery, there is some inflammation inside the eye. During the initial period, we are giving steroids, so the inflammation remains suspended. But when we taper the steroid, because of the inflammation, macular edema happens, leading to Irwin gas syndrome. Irwin gas syndrome is more commonly seen in patients who have cataract surgery plus uveitis. Let us say there is a patient with uveitis and you are doing cataract surgery in that patient. That patient is more likely to develop Irwin gas syndrome. Similarly, if you are doing cataract surgery in a diabetic patient, in a diabetic patient, then also that patient is more prone to develop Irwin gas syndrome. Okay, correct. This is very good. So, yes, absolutely. Patient who is using PG analogs and you are doing cataract surgery in that patient. So that is why before doing cataract surgery, we tend to stop PG analogs and switch to other drugs. At least 10 to 14 days before, we stop the PG analogs and we switch to other drugs that can be done. Okay. Fundus angiography shows like this, which is a petaloid pattern. This is the outer plexiform layer. This I've already told you. This is flower petal appearance. This is flower petal appearance. But this is not done anymore. FFA is not done anymore for CME. Not done anymore because OCT is there. You can repeatedly do OCT. Okay, FFA is an invasive technique. It's an invasive investigation. So you need not do it anymore. Okay. Treatment is NSAIDs, topical NSAIDs. Okay. You can also use steroids. You can also use intravitreal dexamethasone, intravitreal dexamethasone implant. What is the name of this implant? Ozurdex. Ozurdex. Okay, that is Ozurdex. Okay, correct. This is the management. Next, central serous retinopathy, CSR. It is seen in type A personality patients. Type A personality patients. Okay, patient presents with metamorphopsia. Patient presents with metamorphopsia. Okay, there is a hyperopic shift. There is a hyperopic shift. Okay, metamorphopsia is basically distorted type of. So patient can have micropsia, macropsia. Okay, patient can have any of these. Okay, this is painless. Again, painless. Okay, there is it is self-resolving. It is a self-resolving or self-limiting disease. It's a self-resolving or a self-limiting disease seen in type A personality patients, seen in patients who are using steroids, patients on steroids, such as oral anabolic steroids, patients who are क्या बोलते हैं taking inhalers, pump, ठीक है, inhalers, patients on skin creams, skin ointments, ठीक है, these are the. So you have to make sure that the patient stops using steroid. This is a very, very important, okay? Very, very important feature. Patient has to stop using steroid. This is how OCT and FFA looks like. Okay, this is the fluid. It is basically a shallow detachment at the pole. Okay, fluid leading to shallow detachment of retina at the pole, posterior pole. But as suppose there is no definition of how long steroids you can use. Okay, there is no such definition, Anushka. Are you able to appreciate in the below diagrams? See here, this is the fluid collection. This is the fluid collection. Okay, this is the fluid collection, and this is how the smoke is rising. The smoke is rising, and it is taking an appearance of mushroom. It is taking an appearance of mushroom. No, beta, this is a smokestack appearance. This is a smokestack appearance. One is called as smokestack. It can also be called as umbrella. It can also be called as mushroom. Okay, this is the all three. Okay, this can be called as either of them. Somebody is saying ink blot, but in ink blot is less commonly seen. In ink blot, it is like this. This will become like this. Okay, this will then become like this. Okay, this will then become like this. Okay, it will keep increasing in size as if you have kept a ink pen on the blotting paper. Yes, enlarging dot sign. Okay, it is as if you have kept a ink pen on the blotting paper, beta. Okay, understood? Is this okay? Ink blot type. Treatment is self-limiting. Treatment one, it is, I've told you, it is a self-limiting disease. No steroid or stop steroids. No steroids or stop. Okay. Next is if it is recurrent or non-resolving. If it is recurrent and non-resolving, then you do a laser on the leak point. Laser on the leak point. Focal laser. Okay. Laser on the leak point. Correct है. Understood. This is CSR. Treatment I've already told you. Moving to next disease, which is ROP, retinopathy of prematurity. Retinopathy of prematurity. As the name itself is telling, prematurity. Prematurity. So any child born premature. What is prematurity? Child born when? Yes. Any child born less than 34 weeks and weighing less than 2 kgs. Earlier it was earlier it was 1500, but now it has been revised to 2 kgs. Please remember this. Now it has been revised to 2 kgs. Okay, 34 weeks and 2 kgs. Any child who is born between these two, 34 and 36 weeks, and has a ICU stay, whether it is, you can't remember all of them, cardiorespiratory, oxygen therapy, respiratory distress, lung disease, hemorrhage, blood transfusion, sepsis, apnea, poor weight gain, okay, any of these. So child between 34 to 36 is also to be screened, but with risk, risk factors, okay, with risk factors. Correct hai? Yes. So, but please remember, for you, it is this only, 34 weeks and less than 2 grams. This is the criteria to screen, whom to screen. Next important MCQ is on when to screen. So first is whom to screen. Second is when to screen. These are the important MCQs for you. Okay. It should be done at 4 weeks postnatal age. 4 weeks postnatal age. For a very premature child, for a very premature child, you have to screen earlier. You have to screen earlier. Okay. And these are the follow-ups. This is what is the follow-up. If no ROP, 2 weekly. If ROP, then weekly. If pre-threshold, twice weekly. Last screening till the age of 42 to 45. Okay. Last screening till the age of 42 to 45. If no ROP, then you call the patient after every 2 weeks. If you are suspecting some ROP, then weekly. And if ROP is definitely there, then you have to examine every 3 days. Okay, because it can develop in 3 days. Correct? Understood? Is whom and when clear to you? This is what you can expect as an MCQ. This can come as MCQ. Whom to screen and when to screen. These are the two important points. You can remember zones, stages, and threshold disease, then it is good. If not, then you can let it be. Okay? See, zone is 12 clock hours. You divide into 12 clock hours like this. Okay? Like this. This is how the clock hours are there. Zone is optic nerve to fovea, and you take double this distance and you draw a circle. That is the zone 1. That is zone 1. Zone 2 is the nasal retina and tangent. You go from here to nasal retina and tangent. That is zone 2. Zone 3 is outside. Zone 3 is outside. This is the temporal. This is the temporal. This is the nasal. This is the nasal. Okay, correct. Zones is this. Beta, follow-up is simple, beta. Follow-up is, if there is no ROP, patient has no ROP, then you examine after every 2 weeks. If there is some ROP, examine every week. If it is pre-threshold, I'll tell you what is pre-threshold. Okay, I'll explain. See here, beta. Zones are clear. Next is stage. Stage is demarcation line between vascularized and non-vascularized area. Demarcation line between vascularized and non-vascularized area. Ridge is elevation. Ridge is elevation of retina. Elevation retina. Now the retina is proliferating. Then you have subtotal RD and total RD. Okay. This is what is stage. Okay. Threshold is stage 3 or more involving 5 clock hours and 8 non-continuous clock hours. This stage needs laser or cryo within 72 hours. This is a threshold disease. Threshold means bus. Now it is done. We have to do. Okay, this is called a threshold. If the disease is less than this disease, then it is called as pre-threshold. Okay, somebody has stage 3 or more, let us say in 2 clock hours. It is not 5, it is 2 clock hours. Then you call it as pre-threshold. Understood what is pre-threshold? Understood your pre-threshold? If it is little less, it is not so much. Okay, 5 continuous. बेटा ये रहा यार, ये देख इधर, ठीक है, ये देख, very simple बेटा, ठीक है. Let us say there is a disease RD here. There is an RD. RD is what stage? RD is stage 4. ठीक है, RD is stage 4. It is in how many clock hours? Count the number of clock hours. Count the number of clock hours. ठीक है, 4 clock hours. It is not a threshold disease. हाँ 3 कह लो या चलो ये लो 4 कर दिया मैंने. Now this is 4. ठीक है, 1, 2, 3 and 4. ठीक है, correct? Understood? And you have a disease which is here. Will you treat this? Will you treat this? No, it is not, because it is not in 5 continuous clock hours. Okay. So, will you treat this now? Will you treat this now? Will you treat this now? No, still no. Still no. It is 4 plus 1, 5 plus 2, 6, 7. Still no. Okay. You get a disease here also. Will you treat? Now you have to treat. Now you have to treat. This is 8 non-continuous clock hours. Okay. Let us say you have the same disease. Okay. Same problem. But now the disease is like this. Disease is like this. Here. So this is 6 continuous clock hours. So now you treat. So this is what is threshold. When to treat, when not to treat. Correct? Threshold is bus. Enough. Now I will not stop. I will treat this patient. Okay. Rush disease and plus disease, aggressive patterns which proceed very rapidly. Okay. This is rush disease and plus disease. Okay. Treatment is you have to do laser or cryotherapy, ablation of the avascular retina. Basically, you have to kill the retina. You have to kill the retina. Again, you have to kill the retina. Okay. Here also now anti-VEGF injections are being used. Here also anti-VEGF injection are being used. Okay. Correct. Now we come to the final topic, which is RD. RD is of 3 types. I will draw in one diagram. Okay. This is the rhigmatogenous RD. This is the tractional RD. This is the exudative RD. Okay. This is the whole. Okay. Rhigmatogenous. Rhigma is whole. ठीक है. Rhigmatogenous. सर RD है तो स्टेज 4 हो गया, पर इन डेफिनेशन में स्टेज 3, 2 एंड स्टेज विद कंट्रास्ट. बेटा स्टेज 3 और मोर. ठीक है, स्टेज 3 और मोर, तो स्टेज 4 इज RD ना बेटा. ठीक है, एनी स्टेज बियॉन्ड स्टेज 3. करें बेटा. ठीक है, So rigma is basically when there is a break. See here, there is a break. So when there is a break, this retina, when there's a break, this retina tends to fall forward and it is hanging like this. It is hanging like this. This is what is called as rigmatogenous. Take break, which is there, rigmatogenous. Okay. See here, this retina is hanging in front of eye. Okay. So this is what is causing flashes and floaters. This leads to flashes and floaters. This is how the break forms. This is how the break looks. Okay, correct. This is rigmatogenous. RD. MCQ. What are the lesions? These are the lesions in myopia. These are the lesions in myopia which can predispose to RD, lattice and snail track degeneration. There, this is the peripheral retinal degeneration predisposing to RD. Okay, correct. MCQ. High myopia, thick glasses with floaters in eye. What is the cause of this condition? It is RD. Beta RD. Viable in myopia, you will get hemorrhage. Somebody is saying vitreous hemorrhage. In myopia, you will not get a vitreous hemorrhage. Okay? Vitreous hemorrhage will happen because of the bleeding. For bleeding to happen, you have to have new vessels, leaky vessels, some sort of or hypertension, okay, or sickle cell retinopathy, Eales disease. These are the causes of vitreous hemorrhage. The vessel has to be weak. Myopes do not have weak vessels. They have a weak retina. Okay, beta? Correct? Hai? Vitreous hemorrhage will happen because of the weak vessels. So it has to be vascular cause. Traction RD is like this. It is because of tractional band. Okay? Band pulling the retina. Band pulling the retina. Okay. Exudative is because of neoplasms. Okay. Hypertension, some tumors, malignant hypertension. Okay. Systemic vascular inflammatory diseases. Okay. These are the various causes of exudation. Exudation will result in a bullous RD. Okay. Bullous RD. Okay. There is a shifting fluid. What is the hallmark? Hallmark is shifting fluid. The fluid shifts. Okay, that is the hallmark. Bullous RD and shifting fluid. These are the hallmarks of exudative RD. Management RD का laser surgery, cryopexy, vitrectomy, scleral buckling. This much you do not require. One thing that you should be knowing is what is the buckle made up of? MCQ. What is the buckle made up of? Buckle is made up of scleral buckle is made of silicon. Yes, it is made up of silicon. What is the material? The material is silicon. Okay, beta. Previous, this one, beta. Okay, last slide. No, not PMMA. It is a silicon. Silicon buckle hota hai, beta. MCQ. What is the side effect of buckle? What is the side effect of buckle? What is the side effect of buckle? Just imagine this is the eyeball. Yes, myopia. Class till 1 o'clock, beta. When you apply a buckle, the eyeball becomes longer. Okay. So when you apply a buckle, the eyeball becomes longer. Okay. This is what is buckling. Okay, beta. Understood. Vitectomy is, please remember, there are three incisions. One for light source, one for instrument, and third is to refill. Okay. Third is to refill. Beta, in buckle, see here, when we apply the buckle, so in so when we have to do this, what we do? The first step, see here, the first step is SRF drainage. SRF drain. Okay, what is SRF? SRF is subretinal fluid. So first you have to put a needle here first you have to put a needle here and drain the fluid. Once the fluid is drained, okay, then you either push gas here or push silicone oil here so that it will push the retina down. Okay, and then you seal this hole. Then you seal this hole. Okay, or what you can do is you can put a buckle so as to compress this. Okay, so as to push this sclera here. When you push the sclera here, then it gets close to the two surfaces. So either you push the retina out or you push the sclera in. Push the retina out or push the sclera in so that the two layers come together and they, okay, correct, understood. इतना concepts कहाँ जानोगे अब? Optic atrophy. Optic atrophy, three types: primary, secondary, consecutive. Consecutive, no beta, buckle remains in place. Buckle always remains in place. You do not remove the buckle. Okay. Consecutive is a consequence of a disease. Okay. Consequence of a disease. Okay. Correct. Consequence of a disease. Secondary is after optic nerve head swelling, such as papilledema, papillitis, ischemia. Okay, that is secondary. Okay, till 1 o'clock, beta. Primary is without the optic nerve head swelling, that is optic neuritis, integral mass, head trauma, which is there. Correct. So these are the various types of optic atrophy. Okay. Chalky white, dirty white, waxy pallor. These are the three different types of optic atrophies. Okay. With this, we come to the end of retina. Okay. We come to the end of retina. I'll try to wind up till 12:30. Let us see. क्योंकि last में ना there are three very fast topics. One is instrument, one is community optha, one is trauma. Okay, these are very very fast topics. Nothing much to no concepts there. Okay, but they are very very important. Okay. Chalo, let me take a drink then. Take a 5-minute break. Okay, come back. No problem till 6 a.m. अरे वाह. Break for 5 minutes. 11:23. Let us start. Let us start. So uveitis is basically, what is uvea? Uvea is the vascular coat of the eye. Uvea is the vascular coat of the eye. Inflammation of this vascular coat is called as uveitis. Okay. Uveitis can be anterior uveitis, can be intermediate, can be posterior, can be pan-uveitis. This is how it is. Which parts are involved? Iris, pars placata, ciliary body, that's iritis, iridocyclitis. Pars plana of ciliary body, pars plana area is called as cyclitis and pars planitis. Posterioritis is choroid, choroiditis, and all parts are iris, ciliary body, and choroid, that is, all parts are pan-uveitis. Is the name clear? Okay. So this is the area. Iris and iris and iris and pars placata. Pars plana. Pars plana is this, and posterior is choroiditis. This is how you classify. Okay, correct. Now, anti-uveitis, the causes are Angst-Bond, reactive arthritis, bowel disease, psoriasis, Behcet syndrome. These are the causes of anti-uveitis. Intermediate is sarcoidosis, multiple sclerosis. Posterior is sarcoidosis. Okay, pan-uveitis is sarcoidosis, Behcet's, and Blount syndrome. These are the various causes of the uveitis. Uh, we'll discuss about coronary heart disease, symptomatic ophthalmia, ठीक है, HLA-B27, Fuchs, ठीक है. This we'll talk about. Okay. Whatever are granulomatous diseases, TB, leprosy, syphilis, sarcoidosis, VKH, these are all granulomatous. Non-granulomatous, please remember HLA-B27 and Fuchs. These are non-granulomatous forms. Please remember these. Okay, correct. Okay. Let us talk about anti-uveitis. Pain is the most prominent feature. Most prominent clinical feature is pain. Okay. This is a cause of sudden onset painful blurring of vision. Okay. Sudden onset painful blurring of vision. Okay. Now, ये ले बेटा, ठीक है. TB, leprosy, syphilis, sarcoidosis, VKH, symptomatic ophthalmia. These are all granulomatous. ठीक है. Non-granulomatous HLA-B27 and Fuchs. Remember these two. These two are important. These two are important. Okay, correct. Anti-uveitis. These are the signs. These are the signs now. What is this? This is hypopyon. This is hypopyon. What are these? These are KPs. What are KPs? Keratic precipitates. Keratic precipitates. Keratic precipitates. How are they distributed? In a triangle. See here, in a triangle. If you can see here, either here there are KPs, here there are no KPs. Can you see? No KPs here, but in a triangular form you can see KPs. This is what is called as Art's triangle. Where was Art's line? Art's line was there in trachoma. Art's line was in trachoma. Here we have Arts triangle. This is the Arts triangle. Okay. Arts triangle. Okay, correct. Next, Copes nodules and Basaka nodules. Copes nodules is on conepe, on the corner, Basaka nodule at the base. Basaka nodule at the base. Okay, this is what is festoon pupil. Festoon pupil. Okay, this is festoon pupil. On dilation, on dilation of pupil. Okay, see here, these are the posterior syncytiae. These are the posterior syncytiae. Okay, yes. So these are the posterior syncytiae. Please remember this. These are the posterior syncytiae. Okay, syncytiae between the iris and the lens. It is iris and the lens. Okay. Intermediate uveitis present with snowball and snow banking. These are basically your exudates. Okay, these are the inflammatory exudates. Inflammatory exudates deposited at the pars plana. These are the inflammatory snow. What are snowballs and snow banking? These are exudate, round exudates deposited at the pars plana. These are the snowballs. Okay. Posterior uveitis presents in floaters. MCQ. What is the most common cause of decrease in vision in patient with uveitis? It is, yes, it is CME, cystoid macular edema, CME. Okay. What is the most common cause? So CME is the reason, which is the cause. So blurring of vision is due to CME. Okay, beta? Understood? Cystoid macular edema. We have done. So the treatment is steroids. Treatment is steroids. Okay, correct. Posterior uveitis can be choroiditis, retinitis, vasculitis. These are the various types. Fundus lesions with geographical lesions. Okay, that is posterior uveitis. Treatment is by steroids. Treatment is by steroids, either local or systemic. Local can be topical, can be injection, can be intravitreal in any form. Okay? Systemic is oral. Okay? Then you have immunosuppressants, biologicals, adjuvant. Cycloplegic is the most important adjuvant therapy. Most important adjuvant treatment is cycloplegic, and the strongest cycloplegic is strongest cycloplegic. What is strongest cycloplegic? It is atropine. It is 1% atropine. It is 1% atropine. Okay, correct. Remember this. Anti-VEGF we have done, bevacizumab, ranibizumab. This we are aware about. Okay. Now, angstpond, ankylosing spondylitis. It is HLA-B27 associated. Non-gallomatous, I have told you. Recurrent uveitis, bamboo spine, bamboo spine. It is sacroiliac involvement, sacroiliac joint involvement. So there is sacroiliitis, sacroiliitis. Okay. This is angstpond. This is recurrent uveitis. It's a recurrent anterior uveitis. Please remember this. Yes, dagger sign. It is a dagger sign. Very good. Okay. Juvenile chronic arthritis or juvenile rheumatoid arthritis. It's again a non-calamitous anti-uveitis. Important is it is painless. It is painless. More commonly seen in female patients, young patient. That is why juvenile. That is why juvenile. Okay. Post-articular. Patient presents with complication. Patient presents with complication because it is a painless disease. That is why the disease keeps happening. Okay, that is why the disease keeps happening. Okay, band keratopathy we have done. Remember, in cornea we had done band keratopathy. It was there. Okay, glaucoma, cataract. What type of cataract? A complicated cataract. A complicated cataract. है ना? Remember this? Complicated cataract. Yes, calcium deposits in band-shaped keratopathy. Next, Fuchs heterochromic iridocyclitis. See here, it is telling you heterochromic iridocyclitis, that is anterior uveitis. Heterochromic, what does this mean? Different color. What does this mean? It means that one eye affected. One eye affected. Only then it will have a different color. Okay? The affected eye is lighter in color. Affected eye is lighter in color. Okay. What is the hallmark? What is the important feature? It's a low grade uveitis. It's a low grade uveitis. What is the other important feature? Absence of synec. Absence of synec. That's a very important feature. Okay. Next is this, which is pancorneal. Pancorneal. Okay. Capies. Pancorneal capies, which is there. Yes. Next is Amsler sign. Amsler sign. It is what? It is bleeding in the anterior angle. It is bleeding in the anterior. Yes. Low grade means less severe. Yes. It is very, very mild uveitis. It's a mild uveitis. Okay. Amsler sign is bleeding from the angle when doing cataract surgery. There is small bleeding, very fine bleeding, because there are fine blood vessels at the angle. There are very fine blood vessels at the angle. Okay, this is Amsler sign. Okay, patient presents with, very important. Patient presents with a complicated cataract. Patient normally presents with one eye, complicated cataract. Complicated cataract. Okay, patient presents with one eye, complicated cataract. Okay, associated with rubella infection. There is some studies which say it is rubella infection. Okay, correct. Very good. Next is postular Schlossman syndrome, also called as hypertensive uveitis. Hypertensive uveitis, also called as glaucomatocyclitic crisis. Glaucomatocyclitic crisis. Okay. There are recurrent attacks of again mild anterior uveitis. Okay. With raised IOP. So the prominent feature is raised IOP. Please remember. Okay. IOP is raised. Okay. Mild discomfort. Okay. Correct. Treatment is anti-glaucoma. Which anti-glaucoma you will not give? Which anti-glaucoma you will not give? PG analogs. Yes. PG is contraindicated. Apart from this, which is also contraindicated? One is PG analogs. Myotics also. Absolutely right. Pilocarpine. Myotics are also contraindicated. Okay. What will be the drug of choice? What will be the drug of choice? Beta blockers. Yes, drug of choice will be beta blocker. Okay. Then you can add carbonic anhydrase inhibitors. Yeah. Okay. Yes, Timolol. Correct. Post-exhaustive syndrome, glaucomatocyclitic crisis. Is this okay? Now we come to VKH syndrome, Ward Koyanagi-Hara disease. It is a type of panuveitis, the type of panuveitis affecting the pigmented cells of the body, involves eye, skin, and CNS, vision, visual, cutaneous, cutaneous, and head, visual, cutaneous, and head. VKH. Easy to remember. Visual symptoms, cutaneous symptoms, and head. Head में it has encephalitis, meningitis, and hearing. Hearing. Hearing has tinnitus, vertigo. Tinnitus and vertigo. Okay, yes. Cutaneous में vitiligo, poliosis, alopecia, vitiligo, poliosis, alopecia. Visual में one it is panuveitis, second is exudative RD. Exudative RD. Okay, it's a very interesting diagnosis. A patient presents to medicine emergency with altered sensorium, with neck stiffness. Okay, they have made a diagnosis of meningitis. They have sent an optha referral to rule out papilledema. Before doing the lumbar puncture, they sent an optha referral for papilledema. When the ophthalmologist goes there, does an ophthalmoscopy, they realize there is a RD. There is a bullous RD. Okay, that is the point when you inform the medicine colleague कि beta ji, there is a RD with encephalitis meningitis. The patient may be having VKH syndrome. Okay, it's a very interesting finding once you see. Okay, correct, VKH syndrome. Okay, toxoplasmosis. Toxoplasmosis. Age of presentation. Yeah, I've seen young males. Okay, patient 40s. Okay, young males. Okay, correct. Ah. So toxoplasmosis can present like this. This is an active disease and this is a scar disease. Okay, this is a scar disease. This is a headlight in fog appearance. Headlight in fog appearance. And scar disease, this is a punched out lesion. Punched out lesion. Both have come as an MCQ. Both have come as an MCQ. Can we do LP in RD? Lumbar puncture in RD. हाँ कर सकते हैं. RD में lumbar puncture. There is no problem in doing LP in RD बेटा. No issues. Correct है. ठीक है. But obviously RD will not settle. Egg appearance in which disease? Best vitelliform dystrophy. Dr. Anukriti. Best disease in which you do EOG, electrooculogram. Okay. Madam is asking egg yolk appearance. यार यहाँ नहीं लिखते, otherwise you will get confused. If somebody is seeing it later, that person might get confused. ठीक है कि it is in toxoplasmosis. No, so I'm not writing it there. But best vitelliform dystrophy, ठीक है, that is the disease in which you get a egg yolk appearance at the retina, at the fovea. Okay, it's a dystrophy. Yes, it's a macular dystrophy, which is there. And the diagnosis is by EOG, electrooculogram. Okay, understood? Correct. Very good. Next is sarcoidosis. It's again a panuveitis. It's a panuveitis. Okay. This is how candle wax drippings. Can you appreciate these candle wax drippings? These are candle wax drippings. Okay. These are periphlebitis, candle wax drippings. These are there. Okay. This is again a panuveitis, periphlebitis. anti-uveitis, fundus changes, conjunctivitis, everywhere. It's a granulomatous uveitis. It's a granulomatous uveitis. Okay, granulomatous panuveitis. Okay, correct. But the Stargardt disease and Best disease are two different forms of the same syndrome. Okay, correct. It's a type of disorder. अरे ये क्या हुआ है? Am I visible? Hello, 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 hello. ओ भाई, where
यस सर।
is screen not visible ना? Screen चली गई.
स्क्रीन नहीं आ रही। यस सर।
यार ये क्या हुआ यार? ये कौन आया? ये कौन आया और ले गया? कुछ तो कर गया कोई. किसने किसको छेड़ा? Ah, oh, there was trauma. Because of the trauma, we have separative ophthalmitis. It was blunt trauma, and we are coming out of the trauma. It's it. अरे भाई, uveitis is always sterile. हाँ, uveitis is always, uveitis is inflammation. Uveitis is inflammation. There is no pus. ठीक है? हाँ. So after trauma, septic ophthalmia is seen after blunt trauma, beta. It is seen after blunt trauma. It is a bilateral granulomatous panuveitis seen after blunt trauma. Okay. It's an antigen antibody reaction. Antigen is the uveal antigen. It is the uveal antigen. Risk is very low nowadays. Risk is very low nowadays. ठीक है. It is seen after, or नहीं, हे भगवान, not after blunt trauma. It is seen after penetrating trauma. Not blunt. Obviously not blunt. It is seen after a penetrating trauma. Never after blunt trauma. Never after blunt trauma. Always after penetrating trauma. Okay. Now, MCQ. Which is the most risky site? Which is the most risky site? Most risky site. Ciliary body. Absolutely good. Ciliary body. Ciliary body is the most risky site. Ciliary body is the most risky site. Why? Maybe because of, good question, never thought. Because of more antigen there, ciliary body has more vascularity and more antigen there. Okay, never thought. So I'll try to find out the cause. I'll try to find out. Okay. Now, clinical feature. How does the patient present? What is the first symptom? What is the first symptom? Photophobia. Okay. What's the first sign? Photophobia, and there is loss of accommodation. Loss of accommodation. These are the symptoms. What is the first sign? First sign is retrolental flare. Retrolental flare. Okay. This is the first sign. Okay. Apart from this, what is there are retinal pigment epithelium nodules. Retinal pigment epithelium nodules. These are called as Dalen-Fuchs nodules. Dalen-Fuchs nodules. It's a type of panuveitis. It's a type of panuveitis. Injured eye is called as the exciting eye. It is called as the exciting eye. And the other eye is the sympathizing eye. Other eye is the sympathizing eye. ठीक है? Presents after 14 days normally. Presents after 14 days usually. ठीक है? Rare nowadays. Rare nowadays due to use of steroids. Due to use of steroids. In post-op period, we use steroids. Okay, correct. ठीक है? Wherever possible. So now, wherever possible, we try to salvage the eye. We try to save the eye. If the eye has no vision potential, then we remove the eye. If the eye has no vision potential, then we remove the eye. Okay. Salvage eye with reasonable prognosis. Okay. Enucleation, it has to be done within 2 weeks. ठीक है. Mainstay is immunomodulation therapy with steroids. Okay. ठीक है. Understood. Is this okay, beta? Is symptomatic ophthalmia clear to you? It's a very, very important point. Very important disease. Okay. VKH also has Dale and Fuchs nodules. Please remember, VKH also has Dale and Fuchs nodules. Ward coronary heart disease also has Dale and Fuchs nodules. I told you this already when we had talked about Fuchs uncle. Uncle जी की जब बात करी थी, we are done. Antivitis, Fuchs, hypertensive uveitis, VKH, toxoplasmosis, and symptomatic ophthalmia. These are the important topics on uveitis. Uveitis is not inflammation of UV rays. Pendulum, how we show to give stuff? Because beta, if after pain trauma, we repair, we give antibiotics, and with antibiotics we give this steroids under the cover of antibiotics. वॉच यार नॉर्मल वॉच है यार, इसमें क्या वॉच है, नॉर्मल सी वॉच है। हाँ? अब गरीब आदमी का यार ऐसे मजाक में उड़ाओ, मैंने कौन सा रोलेक्स पहन के घूम रहा हूँ। हाँ? गोगा सर के पास रोलेक्स है। हाँ? तुम गरीब आदमी का मजाक उड़ा रहे हो यार। रात को अच्छा लगता है सब रात को करते हुए। टाइम देखो तुम जरा। हाँ? बंदे को नींद भी ना आए। सही है तुम। हाँ? गोगा गोगा सर शौकीन हो सकते हैं, हम नहीं हो सकते क्या? हमारे भी शौक है, हमारे भी इच्छाएं हैं, हमारी भी तमन्नाएं हैं। हैं? हम अपनी तमन्ना मार के रखे हैं। हमारे पास वो भी ना है। हाँ। तुम्हारे पास माँ है। हैं? अरे हाइपरटेंसिव यूवेटिस कर तो लिया बेटा। कौन सी? हाइपरटेंसिव यूवेटिस इस बेटा ग्लूकोमेटोसाइक्लाइटिक क्राइसिस किया तो था। हाइपरटेंसिव पॉस्टनस सिंड्रोम किया तो था। कौन सी आई सैल्वेज करेंगे? वो आई सैल्वेज करेंगे जिसके अंदर हम रिपेयर कर सकते हैं। ठीक है, करेक्ट। ओके सेरिबेलम यूजर्स। अभी चप्पल खाई है मम्मी से। क्यों ऐसा क्या कर रहे थे भाई? तो चप्पल खाई। Immunomodulators, basically यार azathioprine, cyclophosphamide, all sorts of immunomodulators, ठीक है, they can be used. चलें, orbit, these are the various walls of orbit. ठीक है, the mnemonic for floor is pajama. सबका पजामा टाइट है अभी इस टाइम पे। ठीक है, पजामा, पैलेटाइन, जाइगोमैटिक, मैक्सिलरी। ठीक है, फ्लोर इज पजामा। ठीक है, मीडियल वॉल इज मेल्स, मैक्सिलरी, लेक्राइमल, एथमॉइड, स्फिनॉइड। ठीक है, मेल्स है बॉडी, सो बॉडी ऑफ स्फिनॉइड, है ना। मेल्स को बड़ा शौक होता है ना बॉडी दिखाने का। द बॉडी ऑफ स्फिनॉइड। ठीक है, हेयर इट इज बॉडी ऑफ स्फिनॉइड। ठीक है, आता हूँ बेटा, आई टेल। ठीक है, रूफ में फ्रंटल एंड Sphenoid, lesser wing of sphenoid, and lateral wall में zygous, that is zygomatic and greater wing of sphenoid. Zygous, greater wing of sphenoid. Okay, correct. Dr. Baba, that is ठीक है. Medial wall is the thinnest wall. MCQ. Medial wall is the thinnest wall. Floor is the shortest wall. ठीक है. Floor is the MCQ. Shortest wall. Fluid fracture of floor of orbit. Okay. Lateral wall is the thickest and the strongest. This can also come as an MCQ. These are all MCQs which are there. Correct? Okay. Now, proptosis is basically prominence when the eyeball has moved forward. See here. This is how the proptosis is. This is a Knapp-Ziegler test. This is a Knapp-Ziegler test. Okay. Knapp-Ziegler test. Okay. It's a clinical test. It's a clinical test. Okay. It's a clinical test. Okay. Knapp-Ziegler test. How do you measure the proptosis? Exophthalmometer. Okay. It is measured by exophthalmometer. Yes. Different types of exophthalmometer are Lutz exophthalmometer. Okay. One is Lutz. This is like this. It's a scale. Okay. Hertels is this. It can measure both eyes simultaneously. It can measure both eyes simultaneously. This has come as an MCQ. See, INST number 23. Following instrument used to measure proptosis. Okay. Squint के लिए क्या करेंगे? Instrument to measure squint. Instrument to measure squint. Start speaking. Maddox rod, Maddox wing. ठीक है. Maddox rod, Maddox wing. ठीक है. हाँ. Hirschberg test. Absolutely good. Hirschberg test. Hess chart. Lee screen. है ना. Hess chart. Lee screen. Okay. 4 dot sign. Birth 4 dot sign. Very good. ठीक है. These are all there. ठीक है. ठीक है. Very good. So diplopia can also be measured by this, and ptosis is measured by simple scale. Ptosis is measured by simple scale. ठीक है. Correct. Good. चलो. Proptosis with white reflex is ectoblastoma. Proptosis with early loss of vision is optic nerve glioma. ठीक है. Patient present with vision loss. Okay. Proptosis is late feature. Remember this. In optic nerve glioma, patient presents with vision loss. It's a very important MCQ that proptosis is a late feature. Beta. ठीक है. Orbital cellulitis, cavernous sinus thrombosis we'll be doing. ठीक है. This is unilateral. It is cellulitis. Bilateral with toxemia. It is cavernous sinus thrombosis. ठीक है. In a child, if you are having proptosis, suspect leukemia. ठीक है. Okay. Hazy corneal loss of vision is panophthalmitis. Correct. These are the various causes of proptosis. The most common cause overall is thyroid eye disease. It's the most common disease. This is thyroid eye disease. It is more common in female. It is basically an antigen antibody reaction. It's an antigen antibody reaction. Receptor antibodies, they come and attack the fibroblast, leading to adipogenesis and hyaluronic acid synthesis, leading to orbital muscle enlargement. This is the orbital muscle which is enlarged, which is there. Okay. Yes, no specs is a classification. Okay. Tendon sparing, Coca-Cola sign, है ना? Coca-Cola sign. ठीक है, that is there. So, whereas eyelid, soft tissue involvement, proptosis, optic neuropathy, strabismus, these are the various features which are there. Let us talk about them one by one. Eyelid retraction, which is the first muscle to be involved. Which is the first muscle to be involved? No, not medial rectus, inferior rectus. Okay. The mnemonic is Mnemonic is this: I am slow. ठीक है, patients who are hypothyroid are slow. So mnemonic is I am slow. I am so lucky. Okay, you want to no. Patient who has thyroid will not say I am so lucky. ठीक है, patient who has thyroid disease will not say that he is lucky. ठीक है, I am slow. ठीक है, I am slow is for thyroid eye disease. Any other mnemonic? MILS. Mother-in-laws. Mother-in-laws. MILS. Where is this mnemonic used? Medial, inferior. Yes, it is distance of insertion. Distance of insertion of what? Of recti from limbus. From limbus. Okay. This is from near to far. The sequence is near to far. Middle rectus is nearest, superior rectus is farthest. Middle rectus is nearest, superior rectus is farthest. Okay. What does this form? What is the name of the spiral? Spiral of? Spiral of? Ah, ah, Vogue, Zen, सब कुछ भी बोल दो. रात हो रही है तो कुछ भी बोलोगे. Spiral of Tillox. Spiral of Tillox. Okay. Spiral of Tillox. Okay. हाँ, आ रहा था मैं. So next mnemonic is ISNT. Inferior superior nasal temporal. ISNT. This is the mnemonic for glaucoma. Okay. This is the mnemonic for glaucoma. Okay. This is how the disease progression. Disease involves the inferior part first, then superior, then nasal, then temporal. Okay. Disease progression. This is degrees progression. Please remember these mnemonics. These mnemonics are important. They can be asked. Okay. Yes. Inferior, superior, nasal. Nine. The nerve, neuroretinal, optic nerve, beta. Glaucoma, optic nerve. Not visual field. It is not visual field. Optic nerve, NRR. Neuroretinal rim. Neuroretinal rim. ठीक है, NRR. Neuroretinal rim. ठीक है, not visual field बेटा. ठीक है, नहीं बेटा, that is not visual field. ठीक है, हाँ, सुपीरियर 50, नेजल 60 70. यस, यस. नेजल इज लास्ट नहीं बेटा, टेम्पोरल फील्ड इज लास्ट टू गो. टेम्पोरल फील्ड इज लास्ट टू गो, डॉक्टर दीपिका. ठीक है, चलो. आई एम स्लो. Elevation is the most common due to fibrosis of inferior rectus muscle, that is oculomotor problem. Please remember von Graffe sign. ठीक है, this is how I say. वो go slow. वो go slow. Dalrymple sign is डरा हुआ. Dalrymple is lid retraction. Somebody who is scared. डरा हुआ. Okay. डरा हुआ. ठीक है. Stellwack is infrequent blinking. Patient is just looking staring. Patient is just looking staring. Infrequent blinking. This is Stellwack sign. Okay. In case it comes. Proptosis is axial. It is most common cause. It is not dependent on hyperthyroidism because it is not related to the thyroid hormone. I always tell this. Okay. It is not related to thyroid hormone status. It's an antigen antibody reaction. It's an antigen antibody reaction. Okay, it is not it. Okay. Proptosis is in the first year, it is there. After the onset, it is permanent in 70% of cases. If you do not manage it in the first year itself, it will become permanent. Okay. So antibody are forming. The antibody are going to the thyroid also. Antibody are coming here also. Okay. Whatever is happening here will result in hormone. Whatever is happening here will result in, but whether the hormone is normal or not will not have effect here, na beta. Hormone release has no effect. How many antibodies are going here? How many antibodies are going here? You can't tell. Okay, beta. Correct, Dr. Strain Supreme. Optic neuropathy is a compressive optic neuropathy. It is because of compression. Okay, it's a serious disease. Treatment is by steroids, radiotherapy, immunosuppressant, and orbital decompression is there. So treatment is steroids. That is, please remember this. Treatment is steroids. Okay, correct. Decompression is like this. See here how this uncle has become. This uncle from this has become to this. Okay, है ना? अंकल जी अच्छे लग रहे हैं ना? Good. Exposure keratitis, corneal ulceration. These are the problems which can happen. Most common cause of proptosis in middle-aged person. This is INSTD 24, thyroid eye disease. Thyroid eye disease is the not my patient, beta. Sidhuji, not my patient. I am more of a elite surgeon. I am a cataract and refractive surgeon. I do elite work. I don't do all this. Okay? Let us do. Chalo. So, retinoblastoma, it's a malignant neoplasm of the retina. Most common intraocular malignancy of childhood. Okay? Primary. Most common primary intraocular malignancy of childhood. Median age is 18 months. Bilateral will present earlier. Bilateral presents earlier. Where is the gene? 13q14. On which gene? RB gene. RB gene is a tumor suppressor gene. Tumor suppressor gene. It's a Knudsen two hit theory. Knudsen two hit theory. Okay. Basically, both the genes have to go. Okay. Knudsen two hit theory. No, I'm not. Oh my goodness. No, I'm not a vitreoretinal surgeon. Other way. Both eligible. Okay. MCQs. These are again MCQs. Leukocoria. Chorea is pupil. Leuco is wide. Leukocoria, also called as, what is the other name? Amaurotic cat's eye reflex. Amaurotic cat's eye reflex. Amaurotic cat's eye reflex. Okay, this is the most common presentation. Second most common presentation is squint. Okay. Most common in advanced cases is rubeosis iridis. Okay. Most common in advanced cases is rubeosis iridis. Please remember these MCQs. Okay. Correct. Next, it will spread most commonly through a direct spread to the optic nerve. This is the most common spread. Most common pattern of growth is mixed. Most common is mixed. Okay. Most common is mixed. This is the least common and poorest prognosis. Okay. Understood. Okay. Correct. Endophytic is inside. Exophytic is outside. Okay. Makes this both. So one is growing inside the vitreous cavity, the other is growing outside. That is the pattern of growth. Spread is through the direct spread. Please remember this. These are very, very important. Correct hai? These are MCQs. Next, these are histopathology, histopath, which are flexner intestinal rosette, homoerite rosette, and fluoride. These have a neuromuscular core. This is a central lumen is flexner. Okay, neuromuscular cord is this. Okay, these are seen in well differentiated retinoblastoma. In a poorly differentiated retinoblastoma, you will only see sheet of cells. Okay, nothing else. Okay, you will only see sheet of cells, no formation of these rosette or fluorette. Okay, ठीक है. Treatment option is can be local therapy or can be chemo reduction. ठीक है. Chemotherapy is by your VEC, vincristine, etoposide, and carboplatin. ठीक है. Vincristine, etoposide, and carboplatin. Now, somebody asking about enucleation, exentration. Okay, enucleation, exentration. See here. If this is the eyeball, okay, this is the eyeball. Sorry. This is the eyeball. If you just remove the inner contents, this is evisceration. Okay. If you remove the entire eyeball, okay, you cut. This is enucleation. Okay. If you remove the eyeball plus all content of orbit, that is called as exentration. Okay. Remember, very easy to understand. Evisceration, you are removing the viscera. Of the eyeball. Okay. Enucleation, you are taking the nucleus, circle, nucleus, and removing it. Enucleation. Okay. Exentration is an extensive surgery. That is how you can remember. Okay. Evisceration, remove the viscera. Enucleation, remove the nucleus. And exentration, extensive surgery, emptying the orbit. What all is removed with the exentration? You remove the eyeball, extraocular muscles, optic nerve, lacrimal gland, orbital fat. Okay, you remove everything. Okay, that is called as exentration. Okay, but when there are bony mets in the orbit, then in mucormycosis during COVID, when there were cases of mucormycosis, black fungus. At that time, we had done a lot of exentration. Okay, that time we had done exentration is important to save the life. Correct? Optic nerve invasion is the most important performance factor. Poorly differentiated tumor, bilateral, trilateral. These are the we will remove. Yeah, we go up to the periosteum. Okay, we go up to the periosteum. Dr. Tarar Sheikh. Okay, we'll go up to the. We'll not remove the bony wall. Okay, the bone, but periosteum tak it is removed. Okay, these are the causes of leukocoria. Okay, congenital cataract, coloboma, Coats disease, retinoblastoma, ROP, uveitis, endophthalmitis, PHPV. These are the These are the various causes of leukocoria. Leuco is white, chorea is pupil. Okay, correct. Now we come to orbital infections. Pre-septal cellulitis and orbital cellulitis. Understand the diagram, understand the image. There is a septum which is passing from the bone to the upper lid. From the bone to the lid, there is a septum which is passing. This is the orbital septum in the upper lid. Similarly, in the lower lid, and similarly in the lower lid, from the bone to the tarsal plate, there is a septum which is passing. Okay, correct. So any infection which is here in front of the septum, it is called as preseptal. Okay, any infection which is here in the lid is called as preseptal. If the infection has gone behind, if the infection has gone behind, then it will go here also. It will go here also. It will push the eyeball. This is called as a orbital or a post-septal cellulitis. Orbital or post-septal cellulitis. So in one you will have proptosis. In the other you will have only lid edema. Okay? You will have lid edema, but the movements and proptosis will be normal. In the second, there will be proptosis, movement will be affected, okay, optic nerve will be affected, then it is orbital cellulitis. Is this clear by this diagram? Is this clear by this diagram? Okay, yes, vision will be affected. So see this. So orbital, if there is infection in the orbit, there is proptosis is present. Okay, movements are restricted. Vision is affected. Systemic symptoms are fever. Okay, correct. This is orbital. Preseptal. Okay, let us talk about preseptal. Proptosis is absent. Movements are normal. Vision is normal. Systemic feature are usually absent. So understand this. Okay, this is in the lid. This is behind the orbital septum. So just remember the diagram. Just remember this diagram. Remember this diagram. Once you understand this diagram, it is very easy to understand. Okay, correct. No confusion in preceptor and orbital cellulitis. Now, so here, see, this is how the question comes. Decrease vision. So here they are saying decrease vision. They are saying proptosis. They are saying fever. Okay, whether you see the CT scan or not, you need not see the CT scan. Okay, it is orbital cellulitis with cellulitis. Okay, correct, understood, understood. Cavernous sinus thrombosis, when the disease becomes bilateral, then it is called as cavernous sinus thrombosis. Into third, fourth, fifth, and sixth cranial nerve palsy. Okay, these are all there. MCQ, which is the first cranial nerve to be affected in the other eye? MCQ. Which is the first cranial nerve to be affected? Yes, it's the sixth cranial nerve to be affected in fellow eye. To be affected in fellow eye. In fellow eye is the first. Why not preseptal? Why not preseptal? Orbital apex syndrome. But the orbital apex will be where the fifth nerve will not get affected. Okay? In orbital apex syndrome, fifth nerve will not get affected. Why not preseptal? Because beta, in preseptal vision will not get affected, beta. Dr. MSD. Oh, Dhoni uncle. Dhoni ji, you are getting old. Oh, Mahendra Singh Dhoni. Where is your helicopter shot? ठीक है, helicopter shot. चलो. Most common cause of cavernous sinus thrombosis is extension from sinuses. I told you ना बेटा, preseptal में there is no. Okay. चलो. Commonest mode of infection is this. ठीक है. Diabetes, immunocompromise increases. ठीक है. Correct. Investigation and treatment by physician. It's a life-threatening disease. It's a life-threatening disease. So ophthalmologist will refer it to the physician. Okay. Dr. Dilip sir, please take this patient transfer. हमारे बस की नहीं है. ठीक है. It is not our cup of tea. It is not for us. With this we come to the end of orbit. ठीक है. ग्रिसिंगर साइन भाई ये कहाँ है तारा शेख? सीटीबीटी में मिलता है क्या ये? Ocular adnexia, ptosis, ptosis, Marcus-Gunn jaw winking ptosis, synkinetic innervation of levator and pterygoid muscle, okay, nerve, movement of jaw to opposite side. This is how it is. This is Marcus-Gunn jaw winking ptosis. Fifth nerve and third nerve. Correct? ठीक है. Blepharophimosis syndrome. What is phimosis? Phimosis is narrowing. As is visible here, it is narrowing. So there is ptosis, there is telecanthus, there is epicanthus. Okay, there is phimosis. Okay, these are the various features. A, B, C, D. Understood? Okay, correct. MCQ. What is the treated first? In case this patient comes to you for cosmetic correction, what will you treat first? MCQ. It's an MCQ. Telecanthus plus epicanthus. Okay. So when a patient comes for treatment, first is tele plus epi. Second is ptosis. Okay. Second is ptosis. Ptosis is treated later. ठीक है बेटा. It's an autosomal dominant inheritance. It runs in family. So dada has, father has, son has, grandson has. So this is how it is there. Okay. It runs in the family. Written anomalies. This we have done. This is, what is this? Ankyloblepharon. Ankyloblepharon. Okay. What is this? This is symblepharon. Symblepharon. What is this? This is uriblepharon. Uriblepharon. And these are epicanthus. This is what is epicanthus. Okay, correct. These are the various lid anomalies. Ptosis surgery, we have done this. Facianella served operation with a good levator action. It was first given for Horner syndrome. We have done this. It was first described for Horner syndrome, but now it is being done for other procedures also. Okay, it is being done for other mild ptosis also. Okay. Resection is a strengthening procedure. It's a strengthening procedure. Okay. Please remember, strengthening procedure will only be done if the muscle has some strength. Okay. Very easy to understand and remember. The muscle has to have some strength. Only then you will do a strengthening procedure. Okay. See here. If the muscle has no strength, then you will not do a strengthening procedure. If the levator function is poor, then you cannot strengthen it. Very simple to understand. Okay. Then the only option is brow suspension, which is sling surgery. It is Sling surgery. ठीक है? What do? You hang the lid to frontalis muscle. You hang the lid with the frontalis muscle. Okay. What is the supply of frontalis? What is the supply of frontalis? What is seventh nerve? Yes, seventh nerve, beta. Very good. ठीक है? What is the side effect of sling surgery? What is a very significant side effect of sling surgery? Lack of thalamus. What lack of thalamus? Nocturnal lack of thalamus. ठीक है ना? It is very important to inform the patient. अदरवाइज उसकी शादी हुई, पता लगे उसके हस्बैंड ने छोड़ दिया उसको, ये आंख खोल के सोती है. ठीक है? So nocturnal lack of thalamus is a very significant side effect. And yes, poor bells is a contraindication. ठीक है? Poor bells is a contraindication. Yes. Patient will have to sleep with the taping of the eye. Entropion. ठीक है? MCQ has not come for a long time, but we should be knowing. We quickly Jones. ठीक है? Senile. है ना? We quickly run to Jones. है ना? We quickly run to Jones. When we are old, we cannot hold our urine. We quickly run to Jones. ठीक है? Exposure keratopathy can happen, yes. If the Bell's is poor, Dr. Anushka, if the Bell's is poor, then exposure keratopathy can happen. ठीक है? Otherwise not. Okay. Ectropion. Can they use night blindness? But problem is कि it will not cover the eye, na. Night blindness is just only protecting from the light. It is not covering the eye. So the tears which are there, they will get dried up. Even if you are covering like this, the tears are getting dried. You have to cover the lid. You have to close the lid. Okay? You have to keep the lid to the cornea. So you have to protect the cornea. Blinder is basically blinding, not allowing the light to go. Okay? Correct? Ectropion. Ectropion is, again, Bix, Kunt Zimnowski, and strip procedure. These are all Russian names. Okay? Ectropion outside the country. Okay? Remember these names. Okay? Kunt Zimnowski, Bix procedure, and strip procedure. Polish, acha, these are Polish names. ठीक है, thank you for correcting me. Lid tumors. Let's talk about lid tumors. This is our nevus. Dermolipoma. Remember, we have done this. Dermolipoma or lipodermoid, also called as lipodermoid. We have done this. Remember, it is away from the limbus. See here, this is now limbal dermoid. This is the limbal dermoid. No confusion here. No confusion between these two. Here I have not shown the hair wala. It is not having any hair or teeth or anything. This is limbal dermoid, and that is dermolipoma. Okay. Xanthelasma, which is there. Very clear. These are the benign lid masses. Coming to lid cancers. Basal cell, squamous cell, sebaceous cell, renal cell. Basal cell is the most common. Basal cell is the most common. It follows the same sequence as thyroid disease. I am slow. I am slow. Okay. I am slow. It does. Megacanthus has the worst prognosis. Megacanthus has the worst prognosis. Roll border rodent ulcer. Chronic nephritis. This is the basal cell carcinoma. Basal cell carcinoma. Pinnicular दिखाया था ना, done for nevus. नहीं, nothing to be done for nevus. These are all benign masses, only cosmetic correction. If you want, you can get it done. ठीक है? You need not do it. Okay. Correct. Next is squamous cell carcinoma. It is the second most common malignancy. It has a poorer prognosis. Third is the sebaceous cell carcinoma. The important MCQ is it looks like a lesion, presents like a recurrent lesion in a senior citizen. You should send it for histopathology, which is there. Okay, most common in the upper lid because it is arising from the meibomian gland. There, it is a worse prognosis, 30% mortality. Xanthelasma treatment is again excision, beta. Xanthelasma treatment is excision. Okay. Yes, it is because of hypocholesterolemia. Where is the instrument used? Where is the instrument used? For chalazion. What is the name of the instrument? What is the name of the instrument? Chalazion? Aye, not scoop. It is chalazion clamp. Chalazion clamp. Okay. Ring goes where? And plate goes where? Ring goes to the conjunctiva. A plate goes to the conjunctiva. Plate is out. Okay. Ring goes in. Okay. To conjunctival side. To conjunctival side. And plate goes out to the skin side. Plate goes out to skin side. Okay, beta. Correct. This is how we give a vertical nick. We give a vertical incision. It is a vertical incision which is to be given. Correct. Okay. Lacrimal system. This is how lacrimal gland is. Upper granulogus, lower granulogus. So here is the valve of Hasner at the inferior meatus. Here is a valve here. There is a valve here. This is the valve of what? Valve of Rosenmuller. Valve of Rosenmuller. Valve of Rosenmuller. Okay. What is the purpose of these valves? What is the purpose of these valves? Preventing reflux. Preventing any reflux. Backflow. Yes. Preventing any reflux or backflow. Okay. Disorder like congenital LD obstruction, probing, syringing, hydrostatic massage. This is the curricular massage. This is the curricular massage. Okay. Probing after 9 months to 1 year. Surgery at least after 18 months. At least after 18 months. Okay. Syringing probing, curricular massage. Okay, that is okay. 9 months to 18 years. 9 months to 18 months. Okay, you can do 9 months to 18 months. You just keep doing this only. So after 18 months, you do this. Preferably after 4 years. Preferably surgery with surgeries to be done. Surgery preferably after, you will not do it before 18 months. It has to be in at least 18 months, preferably after 4 years, after the age of 4 years. Okay, till that time you try to manage. Okay, dacryocystitis is lacrimal gland. Dacryocystitis is lacrimal gland. Okay, it is a poor hygiene. There. Sorry, dacryoadenitis is lacrimal gland. I think I'm also getting tired. Dacryocystitis is lacrimal sac. Lacrimal sac. Okay. Swelling on the inner aspect of lower eyelid. Okay, this is there. Lacrimal sac. Okay. Treatment is, if it is acute, you do antibiotic and anti-inflammatory. Antibiotic and anti-inflammatory. Okay. For chronic, you do a decryocystoginostomy. Okay. Decryo cysto, no, I'm not sleep. Decryo, cysto, rhino, ostomy. So rhino is nose, cysto is sac, decryo is lacrimal, ostomy is creating opening. What was the so what was the bones which are removed? Remember, the middle wall has males. Remember, middle wall has males. So maxillary and lacrimal. ठीक है. अरे माला क्यों याद करना यार? Males. Remember the mnemonic that we had talked about in orbit, bones of orbit, males, maxillary, lacrimal, ethmoid, sphenoid. So maxillary and lacrimal removed. ठीक है. Yes, males are body. Correct. And ये देखियो डॉक्टर बोबा, you are going to get killed. Okay. The bone is removed and creating an opening in which meatus? In which meatus? Middle meatus. In which meatus? Middle meatus. Okay. Uh, please help. Somebody please help. I need help. चलो. Trauma. So this is very, very important topic, beta. Very important topic. Okay, very, very important topic. Some question is always coming from this. Trauma and instruments. These are the latest hot topics which are there. ठीक है. Trauma and instruments. ठीक है. Please remember this. This is corneal foreign body. ठीक है. This is corneal foreign body. This is how it is. So, can you see this? How many of you think this is iridotomy? How many of you think this is an iridotomy? Don't get confused with iridotomy. Please remember, iridotomy will be here. It will not be in the center, beta, like this. Okay, so don't get confused. I can understand that as an undergraduate, you might think this is a hole in the iris. If you want a hole in the iris, you will not make in the center, otherwise it will lead to a double vision. Patient will have double vision. Okay, iridotomy is always above, near the lid and in the periphery, not in the center. So this is the iron foreign body. What is the most common cause? Most common cause is chisel and hammer injury. Chisel and hammer injury. Most common foreign body is iron foreign body. Most common is iron foreign body. If it goes inside, then it will lead to cirrhosis, beta. If it goes inside, then it will lead to cirrhosis. It is removed like this with the help of 26 gauge needle under topical anesthesia. Under topical anesthesia. Okay. Yes, it's an iron foreign body. Now, very important is copper foreign body is very toxic. Okay. Copper foreign body inside the eye, inside eyeball is very, very toxic. Is very, very toxic. Okay. Yes, it will lead to chalcosis. It leads to chalcosis, which presents with change in the color of iris. Presents with change in the color of iris. Okay. But a topical anesthesia is this proparacaine. Topical anesthesia is proparacaine. Proparacaine. Okay, that is the topical anesthesia. But by symptoms, by history, and by looking at the type of foreign body, iron foreign body will present with rust. Okay, will present with rust. Okay. Now, these are the various injuries. Various injuries that can happen in the eyeball. See here. you can have a sphincter tear. You can have sphincter tear. Are you able to appreciate this? See here, there are minor breaks. These are sphincter tears. Okay, these are the sphincter tears. This is yes. This is iridodialysis, resulting in a D-shaped pupil. Okay, this is called as a D-shaped pupil. D-shaped pupil. Okay, understood. This is how hyphema. This is how hyphema looks like. Okay, if the entire eyeball is filled, if the entire eyeball is filled, then it is called as 8-ball hyphema. Okay, if the entire eyeball is filled, then it is called as 8-ball hyphema. Why 8-ball? Because 8-ball, number 8-ball is black. Okay, it is a black ball. Black ball in billiards has number 8. See, it is looking like a black ball, no, but it is not looking like this. It is looking dark. Okay, see this eye and see this eye. This eye is looking like this ball. This eye is looking like this ball. Okay, it is looking like a black ball. Okay, that is called as 8-ball hyphema, beta. Okay, this is the orbital floor fracture. Orbital floor
क्या?
fracture. Okay, see here.
ठीक.
This results in entrapment of the inferior rectus. Okay, results in inferior rectus entrapment. Inferior rectus entrapment. What else can happen? What else can happen? This is retinal dialysis. This is retinal dialysis. Okay. This is commotio retinae. Commotio retina. Okay. You can have optic nerve sheath avulsion. Optic nerve avulsion. Can you appreciate this? Are you able to appreciate this? The zonules, see here, the zonules were joined. Here the zonules have broken. This is zonular dialysis. Okay, so this one is zonular dialysis. What is dialysis? Okay, iridodialysis. What is dialysis? Dialysis is detachment from the root. Yes, dialysis is detachment from the root. Okay, what is this? What is this? Rosette cataract. This is rosette cataract. And a rosette cataract. Okay. Are you able to appreciate all these traumas? Okay. These are all various types of injuries which can happen. नहीं, exophthalmos नहीं होगा. It will be enophthalmos. There will not be inophthalmos. There will be enophthalmos, beta. Voscious ring. Yes, there will be voscious ring also. Absolutely good. Yes, there will be voscious ring. Okay. There will be voscious ring on the anterior part. ठीक है. Xylem dialysis. Beta, in xylem dialysis, Dr. Tarar Sheikh, nowadays we put a scleral fixated lens. Okay, when there is xylem dialysis, what we can do is we can put a lens here and we can suture it on the sclera like this. It is called as SFIOL, scleral fixated intraocular lens. SFIOL. Okay, beta. Scleral fixated. So, next question. This is how the question comes. The other question comes. Redness after injury, brushing against leaves and thorns while gardening. Leaves and thorns while gardening. Answer is fungal keratitis. Okay, fungal keratitis. Next, hyphema. Okay, these are the hyphema. What is the source of bleed? Source of red is major arterial circle. Source of red is major arterial circle. It is there, the major arterial circle. Okay, it is on the muscular artery, anterior ciliary artery. Okay, they are seven anterior ciliary artery, two from each rectus, two from each rectus, one from lateral rectus. Okay, only one from lateral rectus. Okay, and posterior ciliary artery are two in number. Two in number. Okay, two in number. Very good. Mechanic got injured in the eye, metallic foreign body. You will do a CT scan. You will never do a MRI. You will never do a MRI. Okay, correct. So see this diagram and you see proptosis. Okay, you have restricted movements. This is orbitocilitis. Okay, this is orbitocilitis. Okay, correct, understood. Next, painful ocular movement, diminution of vision following trauma. Pupils are non-reactive. Pupils are non-reactive. It is optic neuritis. Okay, correct, understood. Most frequently fractured site, it is the floor of the orbit. Is the floor of the orbit. Okay, blue fracture. Boy gets punched. He has developed diplopia with upward gaze. Diplopia with upward gaze. What is this? This is a restrictive squint. This is a restrictive squint. What is the test to be done? What is the test to be done? There will be FDT positive. There will be FDT positive. It will result in fracture, floor of orbit, blowout fracture. Okay. There is, see, no proptosis. There is an ophthalmos. So this is how the patient presents. Okay. There is teardrop sign. There is a teardrop sign. Okay. There is an ophthalmos. Sunken eye. An ophthalmos. There is vertical diplopia. There is vertical diplopia. Apart from that, loss of sensation in cheek area. In cheek area. There is a loss of sensation here. You will not be able to feel because of the infraorbital nerve and vessels. Infraorbital nerve and vessels. Yes, vertical diplopia, diplopia in upward gaze. So vertical diplopia and ophthalmos. Okay, this is there. Now, floor of orbit can be a pure or impure type. Pure or impure type. Impure is when the rim was also fractured. Rim is also fractured. Okay? The orbital rim. Okay? If the rim is fractured, then it is an impure type. Pure blowout fracture is when it is only the floor. Okay? Correct. Monocular diplopia with blunt trauma. What is the most probable diagnosis? It is iridodialysis. Iridodialysis. Monocular diplopia, single eye diplopia. It is there like this. Okay. This is what is a D-shaped pupil. Can you see this? How much extensive dialysis is there in the lower part? There is no pupil only. There is loss of pupil. Okay. This is what is zonular dialysis. This is what is zonular dialysis. Now the last is chemical injury. What is chemical injury? What is there in chemical injury? Which is more toxic, acidic or alkali? Acid or alkali? Alkali is more dangerous. More dangerous. Alkali is more dangerous. ठीक है. It results in this. Results in limbal ischemia. It's a poor prognosis sign. Poor prognosis sign. ठीक है? It's a poor prognosis sign. What is the first step in management? First step in management is copious irrigation. Copious irrigation with any fluid. With any fluid. ठीक है? Whether it can be, what kinds of fluid can be there? It can be BSS, that is best. Balanced salt solution, BSS is best. ठीक है? Balanced salt solution. It can be ringer lactate. It can be normal saline. ठीक है? Obviously, it cannot be mannitol or distilled water. ठीक है? You should not use distilled water. ठीक है? Anything which has salts or pure water only, just water, not distilled water. But distilled water is absolutely has no solvents. Na? It will take away, it will suck. There will be osmotic gradient. If you use distilled water, there will be osmotic gradient, beta. It will take. Okay, so you should not. Mannitol also not. Okay, mannitol will also cause. Yes. Okay, it should be isotonic. Whatever solution you use, it should be isotonic. RO water. हाँ, RO कर लो यार. तुम बिस्लरी से धो लो, बिस्लरी. सोडा वाटर ले लो, सोडा वाटर. नहीं नहीं, जस्ट जोकिंग. एनी वाटर, डिस्टिल्ड वाटर इज नॉट टू यूज. ठीक है, एनी वाटर. ठीक है. फर्स्ट स्टेप मैनेजमेंट दिस. हाँ, व्हाट इज द ड्रग ऑफ चॉइस? Drug of choice is steroids. Drug of choice is steroids. Apart from steroids, you have to give antibiotics, anti-glaucoma, lot of lubrication. Lot of lubrication. Lot of lubricant eye drops. ठीक है. Distilled water is not used, beta. Distilled water is not to be used. ठीक है. हाँ, सोहर ड्रॉप. अरे वाह, क्या बात है. So this is a question May 24. Chuna in his eyes. What is the first step of management in this patient? Okay. What is first step? Irrigation. First step is irrigation. Okay. I think there was another question last exam only where they had asked about taking history and irrigation. So there was some confusion regarding history. Don't take history. Okay. There is no history they have given in the question itself. Whatever history is important, they have given in the question itself. ठीक है. चूना पर वाटर इफ वी कीप एक्सोथर्मिक रिएक्शन. हाँ तो बेटा कोई बात नहीं, बट यू हैव टू यूज ओनली. ठीक है. यू हैव टू जस्ट कीप वॉशिंग. आई सेड ना, फर्स्ट इज BSS, RL, रिंगर लैक्टेट. With this we come to the end of. Okay. ये मैं हूँ. This is my selfie. Am I looking good? ध्यान से, बाल थोड़े कम हो गए हैं. बाल थोड़े कम हो गए हैं, बट हाँ तो मैं ऐसे ही हूँ. चलो कम्युनिटी हफ्ता बाद में करते हैं, पहले इंस्ट्रूमेंट्स कर लेते हैं. लेट अस डू इंस्ट्रूमेंट्स फर्स्ट, देन वी कैन डू कम्युनिटी हफ्ता. ठीक है, लेट अस डू इंस्ट्रूमेंट्स फर्स्ट. क्रीसेंट नाइफ. ठीक है. क्रीसेंट नाइफ. व्हाट इज द पर्पस ऑफ क्रीसेंट नाइफ? वेयर इज इट यूज्ड? SICS सर्जरी. ठीक है, SICS सर्जरी. एनी अदर सर्जरी? यस, SICS में टनल. एनी अदर सर्जरी? एनी अदर सर्जरी? टेरिजियम सर्जरी. टेरिजियम सर्जरी. Glaucoma में, yes, you can use in glaucoma also. Yes, you can use in glaucoma also to create the flap. ठीक है. अरे नहीं, कम्युनिटी ऑफ्था में कुछ नहीं है बेटा, 2 मिनट्स का है, वो तो छोड़ देंगे, ठीक है। और आई एम वेरी श्योर डॉक्टर विवेक जैन सर विल बी टेलिंग यू ऑल्सो, बट कम्युनिटी ऑफ्था इज 2 मिनट्स, विल डू इट। Keratome knife, where is it used? To enter the anterior chamber. To enter the anterior chamber. See, please remember this. This is the maximum size. This size will tell whether you are making a 2.8 millimeter incision or 2.2 millimeter incision. How much incision you are making, that will be decided by this size. Okay, correct. This is to enter the anterior chamber in cataract surgery. In cataract surgery. Okay, this is keratome knife. Okay, correct. Next, wire vectors. I have shown you this. I have shown you this to deliver the nucleus. To deliver the nucleus in conventional ECC, conventional ECC, or in SICS. In SICS. ठीक है। Phaco handpiece. Phaco handpiece. What is this tip? Tip is made up of what? There is a titanium tip. ठीक है। Moves at 40 kilohertz, 40,000 times every second. It moves at 40,000 times, like जैसे woodpecker. Okay. हाँ. So this has piezoelectrical crystals. This has piezoelectric crystals which make the tip move. Now, what are the 3 ports? One is the virus. Oh, sorry, wire. It is the electrical port. Okay. One is irrigation. One is irrigation. And this one is aspiration. This one is aspiration. Okay. This one is aspiration. Irrigation, aspiration, and electrical port. These are the phaco piece. Okay. Correct. Next is Bowman's lacrimal dilator and Bowman's probes. Okay, used in DCR surgery, used in syringing probing, syringing probing. ठीक है, correct. Okay, is this okay? Next, so somebody was saying collision scoop, collision scoop, है ना? Collision, this is collision clamp which you have done, and this one is collision scoop. ठीक है, this is a collision scoop. ठीक है, remember this. Wire speculum in any ocular surgery. This is basically to keep the lids apart. To keep the lids apart. Basically to retract the lids. Okay, to retract the lids, we use this wire speculum. Okay, correct. Now, enucleation spoon. This is the optic nerve guide. Optic nerve guide. Where you entrap the optic nerve. ठीक है. Lid spatula is used for lid surgeries. Used for lid surgeries. Okay, used for lid surgeries. ठीक है. McPherson lens surrounding forceps for holding the IOL. For holding the intraocular lens. For suture tying also. It can be used for suture tying. For suture tying. Okay. It is non-tooth. Please remember, obviously, it will be non-tooth. Okay. This is limbs forceps. This is tooth. This has a tooth. So do we pull globe during inoculation? Yes. When doing inoculation, we have to do and we have to pull the eyeball up so that we cut the optic nerve deep. How much optic nerve is to cut? How much optic nerve stump is at least? At least how much optic nerve stump should be aimed? You should aim for at least more than 10 millimeters. You should more than aim for at least more than 10 millimeters. Oh yeah, orbit में how much is the eyeball? How much is the length of the optic nerve in the orbit? सब इधर से जा रहा है, इधर से जा रहा है, ऐसे जा रहा है, zup. Everything is going zup. 25 to 30 millimeters. 20 बेटा 10 नहीं है, 25 to 30 millimeters है बेटा. Everything is going zup है. ये रहा ना, देखो 25 to 30 millimeters. ठीक है, it is 25 to 30 millimeters. So you have to aim for at least from here to here to 25 30. You should aim at least 10 millimeters optic nerve. That is why you go like this. Okay, you trap it here and you pull and you try to cut 28 to 30 millimeters. Okay, beta, correct. Oh sorry, 10 millimeters. हे भगवान, क्या कर रहे हो तुम यार? चलो आ जाओ. ठीक है, 28 is at least more than 10 millimeters. Burn out. Burn out. कहाँ है का burn out? Bana scissor is for cutting the iris. For cutting the iris. Okay. For cutting the capsule. For cutting the capsule. You can do this. नींद आ रही है, बस खत्म कर रहे हैं. Corner scissor is for your corner surgeries like PK, corner transplant. Okay. Correct. Iris hooks, Malaghan ring is there. These are pupil dilators. These are pupil dilators. These two are pupil dilators. This is capsule tension ring used for zonular dialysis. Used for zonular dialysis. ठीक है, zonular dialysis. Corner scissor for penetrating keratoplasty. For keratoplasty, corner transplant, बेटा. ठीक है, corner scissor. For it can also be used for ICC, ICC or conventional ECC. Conventional ECC. ठीक है, ICC and conventional ECC. ठीक है. Okay. These are the uses of the pupil dilator for non-dilating pupil. Ophthalmoscope, direct and indirect. Direct and indirect. Very easy to remember. Direct way you are going close. When you go close, there is zoom, but the area is less. When you go away, the zoom is less, but the area is more. But the area is more. Okay? Direct, erect, indirect, inverted. ठीक है? So direct, erect, indirect, inverted. Magnification, more, area, less. Magnification, less. Magnification, magnification, less. Area, more. Okay? No stereopsis because you are using single eye. There is good stereopsis is there. Okay? Correct. 20 diopter lens is used. ठीक है, here it is. Okay, indirect में inverted, very uncomfortable. Okay, yes, it is an uncomfortable patient. ठीक है, I think with this we can wind up. कम्युनिटी ऑफ टाइम, बस एक दो चीजें इंपॉर्टेंट है यार, बस WHO डेफिनेशन आपको पता ही है, 6/<3/60। बस एक चीज पढ़ लो, ठीक है, दिस इज इकोनॉमिक ब्लाइंडनेस, विजन लेस देन 6/60, सोशल ब्लाइंडनेस, विजन लेस देन 3/60, मैनिफेस्ट ब्लाइंडनेस, विजन लेस देन 1/60, ओके, and total is PL negative. Okay. Economic, when you are economically not viable. Social, when you are not socially viable. Manifest, when it is manifest on your face. You have a blind look. You are looking like a blind man. ठीक है, that is manifest. Okay. ठीक है, 631 ऐसा करना है. Yes. Okay. Work vision. This is work vision. This is work vision. This is walk vision. ठीक है, this is manifest. Work vision, walk vision. ठीक है, because a person height is you are not able to see. ठीक है, correct. Preventive blindnesses which you can prevent. ठीक है, like trachoma, glaucoma, cataract. Can you prevent? Can you prevent cataract? No, you cannot prevent cataract. Cataract is this curable. These two are avoidable blindness together. WHO aims to reduce avoidable blindness. To reduce avoidable blindness. ठीक है, just remember this. The aim of WHO is to no role of vitamin E, no role of any vitamin, no role of any vitamin. What are target diseases? What are target diseases for WHO 2020? Trachoma, onchocerciasis, refractive errors, cataract, and childhood blindness. CH is childhood diseases. Okay, childhood blindness, childhood disease. Okay, trachoma, refractive error. India में, India, does India have onchocerciasis? What is onchocerciasis? What is onchocerciasis? Where is it found? River blindness. Where is it found? Where is it found? No, not China, Africa. It is found in African continent. It's a blinding disease. Okay? It is a blinding disease because it leads to corneal scarring. Okay, it leads to corneal scarring. Yes. Okay. In India, we don't have onchocerciasis. So we removed onchocerciasis and we put three. We put three. Diabetes, glaucoma, and anybody else? Diabetes, glaucoma, and refractory error तो कर लिया. Diabetes, glaucoma, and what? CV, ciliary body, scar, corneal diseases. So Dr. Janisha is the first one, fastest finger. First, corneal diseases, because in India we have lot of corneal ulcers, we have lot of corneal injuries, we are not getting industrial, so foreign body. Okay, this is corneal disease. Okay, India is this. NPCPVI आपको पता ही है, DBCS. ठीक है, I think we should call it a good night. And yo, पढ़ो 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 पढ़ो, पढ़ते रहो, study hard. All of you who have stayed till here, thank you, thank you, thank you. I am obliged. Thank you very much for your support, for being so patient. Thank you to all of you. हाउ मेनी स्टूडेंट्स आर देयर, यही बात सही है, क्वेश्चन तो अच्छा है ये। यार समथिंग लाइक 240, 240 इज अ गुड नंबर। अब ओके, गुड, चलो, मस्त, थैंक यू, थैंक यू। एक गाना, काय का गाना यार? अभी न जाओ छोड़ के दिल अभी परा नहीं, यू आस्क इन एवरी क्या, यू आर व्हाट डू आई आस्क, आई डिड नॉट आस्क भाई, यू आस्क इन एवरी क्लास। END 7:30 मेरे भाई, 7:30। नहीं सर, जाना है मुझे जाना है। गुड नाइट, बाय। भाई ये वियोल पमटा है क्या तरार शेख? मेरे को व्हाट्सअप कर यार, इतना मेरे को फोमो हो रहा है। यू हैव गिवन मी सच अ बिग फोमो। 75 क्वेश्चन बेटा, 75 क्वेश्चंस। हाँ, चलो, गुड नाइट, आई विल शेयर दिस PPT। शब्बा खैर, गुड नाइट है। चलो, लेट मी एक्सपोर्ट दिस। ओके, गुड नाइट, स्टॉपिंग स्क्रीन शेयर, गुड नाइट। पीछे की लाइट, यार अभी मैंने पाकिस्तान में छेद नहीं किया है वहां पे ना, तो मैं इसलिए ऑन नहीं कर रहा था। पाकिस्तान में पहले छेद कर दूं, फिर करूंगा बेटे। बॉम्ब, PDF, कैसे कैसे करोगे सर? इतने छेद करेंगे कि उनको समझ नहीं आएगा कि सांस कहाँ से लें, और टिक 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 टिक। चलो, गुड नाइट।